like to welcome you all to this afternoon session, and it's my great pleasure to introduce our keynote speaker, Dr. Jennifer Zheng. She is the Surgeon-in-Chief and the James Utley Professor of Surgery at the Boston University School of Medicine. She's a highly regarded surgical oncologist and gastrointestinal surgeon, especially specialized in surgery of the upper GI tract. She graduated from the University of California, San Francisco for her medical degree and completed her master's degree at Harvard Chan School of Public Health. She completed a general surgery residency at the Massachusetts General Hospital and a research fellowship in molecular medicine at Harvard Medical School in Boston's Children's Hospital, followed by a clinical fellowship in surgical oncology at the University of Texas MD Anderson Cancer Institute. Upon completing her residency and fellowship, Dr. Zheng joined the faculty at the University of Massachusetts Medical School. In April 2006, she was named the first research scholar of the Pancreatic Cancer Alliance and later won a Howard Hughes Medical Institute Physician Scientist Early Career Award. The following year, she was the founding director of SOURCE, which stands for Surgical Outcome Analysis and Research, a research initiative to improve treatment strategies for surgical conditions and to develop tools to assess and reduce risk. She became later the first woman in Boston to lead a surgical unit in a medical school and teaching hospital when she was appointed chief and chair of surgery at Boston Medical Center. During 2019, Dr. Zheng was selected as director of the American Board of Surgery. As a result of her research, she was also named to various editorial boards of several journals, including the deputy editor of JAMA Surgery. In 2021, she was named president-elect of the Society of Surgery of the Alimentary Tract, and she's a founder and past president of the Society of Asian Academic Surgeons. Dr. Zheng has published more than 180 peer-reviewed journal articles on reducing surgical risk, cancer biomarkers, and on developing models for cancer treatment sequencing strategies with a particular focus on pancreatic cancer. She is an internationally acclaimed expert in evidence-based surgery for pancreatic cancer, and for this reason, she is the ideal expert for giving us the keynote lecture on pancreatic cancer surgery, evidence and future. Jennifer Zheng, the floor is yours.
Thank you, Helmut. That was wonderful. These are one of these things that you wish was recorded so your mother could actually see it, because my mother still asks me if the people will allow me to operate on them and all these kinds of questions that I'm sure you get as well. Let me see if I can figure this out. Button? No, I can't figure it. Green arrow. Aha. The big button. These are my disclosures. None of them have anything to do with what I am going to talk about today in particular, except I do have one disclosure, is I'm really actually bad at PowerPoint, and somehow the last time I gave a talk, it was for the initiation of the Peruvian chapter of the SSAT, and somehow I managed to, like a genius, embed the SSAT logo in all of my slides, and I can't figure out how to get it out despite help from the audience and all that kind of stuff. So, but I do want to say though that you should definitely all join the SSAT, because I'm the president-elect. Dr. Jean-Nicolas Votet is the president. We all look forward to his address in San Diego in less than a month or so, and it's a great organization. So I'm just saying that's why it's embedded in all the slides. Not that I'm really, really bad at PowerPoint. So we all know that I'm speaking to the audience in this room, and all of you are experts, and most of you could give this talk better than I could 10 times over, and I know people watching online as well. But I do see pancreatic cancer as a war. I think it's, and how do we win that particular war? All of us would be happy to be out of the pancreatic cancer business and operate on benign cysts and prevent cancer before it starts. So I divided it into a number of categories, only some of which we influence primarily as surgeons, but all of which we touch. And so there's a need for better targets. We need better understanding from basic and translational research. We need better tools, molecular tools, including all the various omics and the targeted drugs, which are now finally starting to make some sense in pancreatic cancer. And there's technical issues. There's the learning curve. I know there's a published on the learning curve in pancreatic surgery, pancreatectomy, and now minimally invasive pancreatectomy. And those are all meaningful questions. And then vascular resection and MIS. In our world, I'm not going to touch on this today in particular, but I will say a strong sense of mind in terms of how we win the war is that we still know that most pancreatic cancer patients that deserve resection and adjuvant therapy don't get it. There's a tremendous racial disparities in how we execute pancreatic cancer treatment, at least in the United States of America, and there may be analogous analogies in other countries and other places, but pancreatic resection and adjuvant therapy should be offered to all those who are eligible to receive it. And I think we can talk about that later, or we can talk about that in another subject, but I think that is incredibly important and something that we should remember. But finally, we need better strategies. We need neoadjuvant therapy, I will argue, and that's the main focus of this particular talk. And there's risk prediction and patient selection, who gets surgery, who doesn't, and who gets chemotherapy and who doesn't. And there's population-based efforts. So I'm going to focus most of this talk around neoadjuvant therapy. And I think that's the only real area of argument. I would argue that the only real area of argument for neoadjuvant therapy is resectable disease. This is a slide, and much of what I talk about is due to a pivotal 18 months of my life where I was a clinical fellow at MD Anderson Cancer Center, where I will say I really learned, like many of you, I don't know if Sai is still here, but many of us learned that actually it makes sense for all diseases, but potentially the area of argument is resectable disease. So this you can obviously see as expert pancreatic surgeons where the tumor is, where the SMV is, and the SMA, and that arrow pointing to the area, that magical area of clearance between the vessels and the tumor. So I will argue that pancreatic ductal adenocarcinoma is always metastatic, and it's just a question of whether it's macroscopic or it's a occult metastatic disease. A lot of my thinking around this it has been infused by MD PhD named Christine Icabuzzi-O'Donoghue, who was actually a Boston University School of Medicine MD PhD student, and then obviously went to a storied career at Hopkins and now right around the corner here in New York. So to grossly oversimplify her papers, she and her group were able to demonstrate different clones from their rapid autopsies from pancreas, from various sites of metastasis, including peritoneum and liver, lung, et cetera. And in so doing, they did complex mathematical modeling that it would require someone who's taken my son's current math class in high school that I can't actually really understand myself, but to be able to model the various clones, at which point the progenitor cell becomes a tumor cell, that then becomes a metastatic clone. And in their modeling, they basically identified that pancreatic cancer has been developing for the better part of a decade before it's identified in a potentially resectable, macroscopically non-metastatic location. And their paper in Cell early demonstrated that, or proposed the argument that there's aggressive systemic therapy should be given early, after the diagnosis, and not after we perceive macroscopic metastatic disease. So I'll move from there to say that we also know that there is a U.S. failure to treat. Carl Villamoria, who was trained at MD Anderson, Northwestern MD Anderson, is now a professor at Northwestern, demonstrated when he was a research fellow at the American College of Surgeons doing the NCDB before there was the National Cancer Database, that there was a U.S. national failure to operate, and he published it in Dr. Lilimo's little journal, The Annals of Surgery. Gulnara Kasimova is a a clinical surgical oncology fellow at the Ohio State University. I know that Tim Pollock, if he's was here earlier for sure, and he would want to make sure that I said the Ohio State University for Surgical Oncology under Alan Sung, who is now moving to the University of Virginia as chair. But Gulnara Kasimova was a categorical resident at Dartmouth and was a research fellow with me for 2 years. And she came up with this hypothesis herself. So this is what we do at SOAR, which you've heard about is our research group, Surgical Outcomes Analysis and Research, that is now based at BU and BMC. We take our research fellows, and they come from all over. We are lucky enough to have research fellows from Dartmouth, from Yale, where someone's coming from MGH, and obviously from Boston Medical Center and BU and BIDMC, many of who've presented today or previous days on virtual posters and orals. But she came up with this proposal herself. I did not give her this research project. I did not give her the idea. When somebody starts with us, we may put them on a project. I may have an idea. Dr. Tevye Sachs or other PIs may have an idea. The senior research residents may involve them on projects. But then it's kind of like Star Wars and the Sith. There's always a junior and a senior, or an apprentice and a master. And so by the time Gulnara was in her second year in the lab, she came up with this research hypothesis and the database and how to do it herself. And this was presented at the IHPBA in Brazil. So this is where, and it was published in Surgery. So, but what she demonstrated, this is the main slide that I think is important, is that in the United States, at least, we fail to treat pancreatic cancer patients systemically. And you can see here that only a small majority of patients at stage 1 disease actually get resection. A lower percentage of patients get resection at stage 2 disease, and a trivial minority of patients obviously get resection at stage 3, none at stage 4, but many patients at stage 3 and 4 do not get any treatment at all. No adjuvant therapy, no systemic chemo, obviously no surgery. So this is updated from 8 years before from Carl Billamorio's work. And so why do we not give adjuvant therapy in resected patients? There are a number of reasons. Some are treatment related, and there's surgical complications, as you know. Of course, we're all perfect and we have no complications, but those people that do have complications, their patients can have a delayed recovery and not get adjuvant therapy in a timely fashion. The largest window that we could accept adjuvant therapy would be 3 months, but honestly, it's probably 6 weeks, the time at which we should be hoping our patients would be getting adjuvant therapy. Jim Carroll, who was a research fellow with me from UMass, is now an attending at UMass, but he demonstrated in JOGS that the inpatient mortality was 8.1% nationally after pancreatectomy for cancer. But readmissions is higher. So readmissions was 16% within 30 days. Tara Kent has done some important work on readmissions. I know she's in another room, but I just spoke with her. And 53% at 1 year, also in the Journal of Gastrointestinal Surgery. Some of them are patient-related. Why do patients not get adjuvant therapy? Age, preoperative performance status, medical comorbidities. Patients may actually choose not to have surgery. Refusal is a word I've stopped using in research. Now, I think patients choose things, and whether or not patients are non-compliant or they refuse, I think especially the research that we're doing around the era of disparities in health equity demonstrates that we probably shouldn't say things like refuse or declines, but figure out the choices that patients make around how we're presenting their choices to them. But sometimes it's disease-related. The patient progresses. So this is Jim's work again, Jim Carroll's work again, but I had this hypothesis at some point when I was young. I was just a junior attending. I was probably still on that Howard Hughes early career award that you alluded to. I thought that there would be some tremendous perioperative risks that we know after pancreatectomy. So the patient has a fistula and has a terrible, pseudoaneurysm and dies, et cetera, or dies of sepsis. And then there would be this golden period where they're done with their operation and then they are fine and they're just recovering and they're having chemo or whatever. And then they would die of disease progression, because we know most people die of disease progression. But actually, Jim found that was not the case. There's a constant mortality risk. Once you get out of the postoperative period, obviously where there is a significant risk, it's actually constant over time. So there is no golden window for a pancreas, for the average pancreas patient. So many of you are at elite single center cancer centers where cancer is the only thing that you do. There are you'll see my biases, but there are places where there's, I'm joking a little bit, but there's experts of the left breast and there's experts of the right breast. And so that's, people have said, when people get up here and talk about neoadjuvant therapy, well, that's okay at pick your elite place that only does neoadjuvant therapy, but it actually doesn't work in my real world. In Boston, you can't swing a dead cat without hitting an expert pancreas surgeon or being at a quote-unquote high-volume center. So what happens if you offer this patient neoadjuvant therapy and they go across town or just 20 miles out of town and find somebody who's like, well, yeah, I'll operate, because my chairman says that I need to make this many RVUs. And I mean, not that you're actually thinking that, but you want to do an operation. And when you're a surgeon, you want to operate. You know you can cure people with operations, so why wouldn't you want to operate? Why wouldn't you want to give person that chance? So in the elite cancer, with that big caveat, in the elite cancer center experience, that a neoadjuvant strategy has a higher rate of multimodality completion. And this is Qingwei Tseng, who's probably here, but he's no relation to me whatsoever, despite the fact that he misspells his name T-Z-E-N-G. But he also found that the multimodality completion improved survival compared to others. So again, I would say that resectable pancreatic adenocarcinoma is about equal to occult micrometastatic disease. And this is Tim Pollack and Chris Wolfgang, again, who works down the street, at a debate for the SSAT last year. And I debated Chris, and I think anybody who was there will agree that I won. But systemic therapy, it's a systemic therapy for systemic disease. More than 75% of patients who are diagnosed with locally advanced disease or metastases, but more than 95% of patients have metastases at diagnosis or will develop metastases during their follow-up. This is a patient shared with permission of my chief of surgical oncology, Dr. Tevye Sachs, who did his residency at Beth Israel Deaconess Hospital under Dr. Tara Kent and Mark Callery, and then him pictured with some of his mentors along the way, Dr. Cameron and Mrs. Cameron, as well as Dr. Warshaw, who knew him as he was growing up. But this is a patient of his. We've all had this patient. So you had a patient he did a Whipple on, and 3 months later, hadn't even had adjuvant therapy yet, the patient blossoms with metastatic disease in the liver. That is not a patient that any of us would do any favors by operating on. So what are the barriers to a neoadjuvant strategy for pancreatic cancer? Well, there's clinician acceptance, as I mentioned. You need surgeon buy-in for this. And I admire my colleagues in the Netherlands and other places where they can actually randomize patients and actually have patients comply, to use another word that I don't like very much, with randomized treatment. I know Mark Besselink at least was here earlier. I would welcome any comments on how we can actually herd the cats of surgeons and medical oncologists and patients more effectively into a randomized clinical trial in places like the United States. But short of that, I think we, again, like to do what we're good at, and we know what to do. And if a patient gets sent to a surgeon, it is often, if they look resectable, it's hard not to offer that patient resection. So at least in the US, no randomized controlled study has been done. And I would argue that there's no randomized controlled study will be done with a long course of neoadjuvant therapy, and then again, all credit to the study which is being done now. I would argue that isn't necessarily the longest course of neoadjuvant therapy, but that will actually determine whether or not upfront surgery or neoadjuvant strategies are appropriate in resectable pancreatic cancer. We'll see. I mean, maybe the accrual will be wonderful. It is very hard, in my estimation, even at top academic centers, to accrue people in a randomized study to surgery or neoadjuvant unless it's really presented as gospel. So this is a study by Susanna de Hus, who's going to be a resident in general surgery at Beth Israel Deaconess Medical Center starting, I think, July 1 or June 23rd of this year. So congratulations to Dr. Kent for recruiting a wonderful, wonderful person who many of you know, but if you don't know her, she will be a force to be, already is really, but a force to be reckoned with in the pancreatic cancer field. She's experienced in both basic science research, translational, and now outcomes research. But she did this decision analysis that was using a Markov model, which basically demonstrated that neoadjuvant therapy offered substantial benefit in terms of survival, and when you put quality of life in, it offered an increased benefit. This is a paper from another institution down the street, Memorial Sloan Kettering, which has been much looked at. It came out about the same time as those papers by Christina Acapuzzi-O'Donoghue that I alluded to. But it basically showed, using the impressive Memorial Sloan Kettering databases, the survival curves of pancreatic cancer adenocarcinoma patients over time. And at the time when the study was done, looking at the 2000s, which are in green here, there was no change in the curve. I will say this is immediately after the failure of all the GEM doublet studies, and now with FOLFIRINOX and with Gem-Abraxane and some glimmerings into targeted therapy that works in pancreatic ductal, certain subtypes of pancreatic ductal, there's a little bit more light for the adjuvant therapy. But again, these curves had not changed for decades and need to change. So people often think of the centers that I adore and worship as the standalone major cancer centers as a form of Disney. When you talk about a center like mine, which is Boston Medical Center, this is MD Anderson Cancer Center, of course, but a center like mine, Boston Medical Center, or any place that has a lot of different concerns and doesn't have necessarily a unifying cancer policy, how do we get neoadjuvant therapy to be accepted for resectable pancreas cancer? This is BMC, and I hope you'll come visit if you haven't already, but I consider it very much the real world. So neoadjuvant in real life. There's upfront surgeries on the left, you'll see neoadjuvant is on the right. Upfront surgery is okay, but I still would argue it's not the preferred treatment for most. In patients that are healthy or young and that are likely to withstand surgery okay and not have a complication, but you all know that we have patients that are great and still have a complication. So all those prediction rules that I spent my early career doing, which I didn't bore you with today, they're not perfect. Dr. Vollmer used to get up and say to me when I was presenting my early prediction rules, like, how can you predict how come none of these rules are 100%? How come none of your area under the curve is perfect? You can't. And I don't know if Dr. Pitt is here at this particular meeting, but all the NISQIP calculators, they're not perfect. So even if you think the person's likely to withstand surgery, they may not. No definitive tissue diagnosis. Now, obviously, in most centers, that's going to be a non-starter to not have a tissue diagnosis and give chemotherapy. But in general, you can get a tissue diagnosis. You just have to try harder. Someone who's unstentable and has jaundice. Someone who's unstentable and has biliary obstruction, that potentially is room for advocating upfront surgery, at least to bypass them. And then potentially patient preference. Obviously, we're not going to boss our patients around. Our job is to tell them what we recommend and give them the evidence, and then we want to support any of their decisions that they make that are reasonable. And social determinants of health. So again, Boston Medical Center is the real world. My patient population at Boston Medical Center is incredibly diverse from all different diverse economic standpoints. I have people that fly to see me or one of my partners or something else from all over the world. And then I have people that are from the Mass and Cass encampment, which if anyone from Boston knows is this homeless encampment down the street. And so potentially somebody who's homeless or somebody who is not responsible or doesn't have the wherewithal, and we can't give them the wherewithal to make it to their neoadjuvant appointments, would benefit from upfront resection. But what favors neoadjuvant? Somebody who has kind of marginal performance status, we would favor neoadjuvant. Of course, the med-oncs are going to tell us, well, they're not going to tolerate GEM, but if they're not going to tolerate GEM, they're not going to tolerate surgery. So as somebody wise once said, there are borderline resectable tumors, and there's also borderline resectable patients. And so I think using a neoadjuvant test for patients is actually not a bad thing to see if they can tolerate their FOLFIRINOX or even their GEM. That is actually a little bit of a test. There's also a test that they're actually going to potentially have the wherewithal, mental and familial and everything, to be able to tolerate what's going to happen to them after a big surgical resection. And you can always stop chemo. You can't really stop an operation after you've already done it. Biopsy-proven pancreatic cancer obviously favors neoadjuvant. And if there's vascular involvement or borderline resectable disease, we all, I think, pretty much have gone on board that in general, if you're planning on doing a vascular resection or if it's a borderline tumor or both, depending on how Katzian you want to be in your definitions, it's time for neoadjuvant therapy. And then again, we talked about the social determinants of health, which you now know impact impact our patient outcomes tremendously. But overall, for both of these strategies, for any strategy regarding pancreatic adenocarcinoma, I would strongly argue that a multidisciplinary team and a patient-centered approach is important. So not just one driver of the multi-D team, not that I'm the surgeon and I know what's right and I'm just going to ask other one and get their blessing, or vice versa. The med-onc has an opinion and they just get a surgeon maybe involved at the last minute to ask a question. It really needs to be a true partnership. So this is a patient shared with obvious permission. So I'm old enough now that I know people that have been around for a long time with pancreatic adenocarcinoma. So this is a guy who was diagnosed with pancreatic cancer, painless jaundice, went and had an operation at a major hospital in Boston, and was found to have disease involving the hepatic artery, and right hepatic artery. He had attempted resection, aborted, and had it open, double bypass, biliary bypass, and a gastric bypass. And then he was told, this is what he told me, but he was told that he had 6 to 12 months to live, and was told to go, if he wanted to fight, he could get some palliative chemotherapy. He's a smart guy, and he did his own research, and he falls in a demographic that is able to travel and able to pay for stuff and able to take time off of work, which are all things, again, I'm not going to talk about today, but really do matter. And he found actually a center in Texas that told him he could get more than palliative chemotherapy. So he went, and he saw this guy who has now cleaning his boat, but it's Doug Evans if you don't recognize him. He found him in Texas, and despite their lifelong antipathy about some things, they bonded over other things, and Doug recommended neoadjuvant treatment. He ended up having neoadjuvant treatment back at home in the Boston area with both chemo and radiation, and he came back, and when I was a fellow, he was resected at MD Anderson with a vascular reconstruction of his right hepatic artery. And he's now 19 years out. I get to follow him. That's my job, is to follow all of Doug Evans' patients that live in the Massachusetts area. So he and his wife, who you see here, they have truly won the war on pancreatic cancer. I think now he says he just needs to worry about things like getting old, like his knees, his old football injuries afflicting him, and all that kind of stuff. So I think it is possible to win the war on pancreatic cancer, but we have to be really careful and think about which tools you want to apply when. And that's my last slide. Well, thank you very much for the floor, and I appreciate you all listening to me.
Thank you for your excellent presentation. Are there questions? We have time, 2 minutes time for the short discussion. Jennifer, what is the role of tumor boards in the United States? Because from your presentation, I got the impression when you move in a surgical door, the surgeon is evaluating the patient and is finally deciding what is happening with him. In Europe, if the patient comes before the decision is made what is done with the patient, we discuss these patients in an interdisciplinary tumor board where gastroenterologists, radiologists, surgeons, oncologists are discussing what is the best treatment strategy.
Thank you. I think it varies institution to institution, because I think to have a Commission on Cancer accredited program, you have to have a multidisciplinary tumor board, but we all know there are tumor boards in which there's one dominant or a service that is dominant, and often that if the surgeons are very dominant people, and I suspect that there are others which are not. I just maybe happen to be I'm a pancreas surgeon, somewhere around a lot of strong-minded people. I think it's not a requirement that every patient gets presented in a tumor board in the United States, though. It's that some do, and individual doctors need to decide to put their patients on the tumor board. There may be some institutions in which all patients are discussed at a multidisciplinary tumor board, but to be honest, we see so many patients. At my center, which is a medium-sized center, we see hundreds of patients with pancreatic cancer a year, and to present all of them in our multidisciplinary tumor board would be impossible for time to actually have a good discussion. So I think it's not a mandate that all are presented. It is a mandate that for Commission on Cancer accredited, ACS accredited hospitals, that there is a tumor board.
Thank you. If there are no more questions, thank you for your presentation.
Thank you. Let's see how
No, good afternoon. Tom Gallagher from Dublin. I'm delighted to introduce our next speaker, Dr. Alice Way. Alice is a surgical oncologist here in Memorial Sloan Kettering in New York and is an associate professor in the Weill Cornell School of Medicine. She's co-director of the surgical initiatives in the Rubenstein Center for Pancreatic Cancer Research. Dr. Way graduated from McGill in 1995 and undertook her residency and subsequent HPB fellowship in Toronto, where she subsequently worked on staff until her move to Sloan Kettering. During her training, she also completed 2 masters in cell biology and clinical epidemiology in the University of Toronto. She's well known to everybody in this audience. She's widely published not only in HPB surgical oncology, but also in health policy and quality improvement with over 6,000 citations and a H-index of 33. I greatly look forward to hearing her insights on the centralization of pancreatic cancer surgery.
Thank you very much.
The floor is yours.
Thank you very much for the invitation to speak. And actually, I think my talk segues very nicely after Dr. Seng's talk looking at pancreatic cancer and also some of the questions that came up during her talk. So I have no disclosures that are relevant to this talk. So I hope that I don't speak for the whole 30 minutes, so there's an opportunity for some discussion. I think the biggest challenge is that there's a lot of data, but what do we do with the data? So my question is, the first thing I want to answer is, well, why should we centralize complex cancer surgery, with pancreatectomy being sort of the ideal or index case for that? And I think we all know the answer, but I think it's important to be explicit. We're doing it to improve quality of care. We're not doing it for costs, and we're not doing it for efficiency, at least us as the surgeons in the room. So, there is a plethora of data that looks at the relationship between procedure volume and outcomes. And it goes back to 1979. There's many talks today, and during the session I've talked about it, but at Memorial Sloan Kettering, they looked at SEER data as far back as 1998. Dr. Brennan's team looked at complex cancer surgery, including pancreatectomy, hepatic resection, esophagectomy, and pelvic surgery. I can't even see from here. I'm getting old. And what you can see is that even in the earlier data, you can see that the pancreatectomy data showed a clear relationship where the perioperative mortality decreases as the volume increases. And of course, Berkmeyer's seminal paper looked at, you can see this high volume relationship both at the institution level, and you can see the pancreatectomy is on the right with the higher volumes. You can see higher volumes only determined by 16 cases in that study. And also you can see the same thing at the surgical volume. So both at the level of the institution contributes a lot to what we're seeing, but also the surgeon contributes a lot. And this volume effect has been demonstrated in many, many countries and many procedures. And on this side here, this is a nice report that came out of Canada that looked at the entire country of 30 million people, of which some of the regions had some standardization and some regions did not regionalize. And you can see that the relationship between perioperative mortality and pancreatectomy is clearly associated. So high volume centers with an annual volume of up to 100 cases per year had much substantially lower perioperative mortality than lower institution centers. And again, this nice study from France looked at over 225,000 patients that had a multitude of complex digestive disease operations, and they could see for pancreatectomy that, of course, there was a high volume, low volume relationship. Interestingly, many studies, and I won't show the data here, but the French study particularly looked at the fact that some high volume operations, so for example, it crosses over, so that if you are doing high volume esophagectomies, high volume lung cancer surgery, in fact your volumes, your outcomes in pancreatectomy are also better. So there's something about institutions that do complex surgery in general that translates into better outcomes, not just for pancreatectomy, not just for esophagectomy, but across the board. So there's a signal there, and I think that's what we're all trying to capture when we think about centralization. So really, just to reiterate, I think we do a poor job of convincing people why. The reason to centralize is not so I get more patients than you, but really is to improve the quality of care. And I think that's something easy to remember. Sometimes people sit in the room, they see someone like me, I'm a high volume surgeon, and they think what I want is to get all the cases. That's not actually what the goal is. The goal is to centralize, to improve quality of care. We know that it's very strong, the volume outcome relationship for procedures. We can discuss the nitty-gritties of 11 cases or 20 cases or 50 cases, but it is very clear that the higher volume you do, the less mortality that you get, the better oncologic short-term and long-term outcomes, the lower the costs, and we're not going to talk today about value, but the increase in value that you offer for the patient. We see this volume outcome affect institutions and surgeons across diseases, across procedures. So that's what we have to think about when we try to centralize. Despite this, despite the fact we've known for over 2 decades that centralization works, we know that centralization has not been achieved in most places. And it's not for lack of trying. So if you look in the US, where I'm currently based, the US, the regionalization efforts have been very limited. So if you look at the first hospital system that tried to implement a regionalization strategy, this was the Take the Pledge campaign, they had a very, very low number of targeted patients, 20 pancreatectomies per year. And you can see, and this data is a little bit old now, from 20, but if you look from up to, is that you can see up to 2012 that you can see that most 90%, 89.2% of hospitals are low volume, and that most patients, just under 50% of patients, have their operations performed at high volume centers. So most hospitals are low volume, intermittently low volume, occasionally intermittent high volume, and most patients get surgery in what we would consider low volume centers. Similar to the Leapfrog initiative, which was a public reporting initiative trying to engage payers to pay for high quality surgery, very modest goals, 10 pancreatectomies per year per surgeon, 20 per hospitals. This recent study looked from, that was just reported last year, looked at 2,100 hospitals, which is 70% of the acute care adult sites. Less than 10% met the standards in 2019. So our efforts to regionalize are still limited, and so there is a knowledge to action gap and implementation science gap between best knowledge and what we're actually doing. Now, so Pierre Clavien put together a group of surgeons trying to look at building a consensus towards centralization. And what we mean by centralization is the idea of a deliberate process of concentrating, consolidating resources, not just volume of cases, but infrastructure, staff, human resource infrastructure, knowledge, materials, and research to try to improve the quality of care. So this is what really we're thinking about in terms of a deliberate process. Really what they do, we're not hoping for is a secular or a market-driven centralization. So what you really want to see here, and you'll see, I'll reiterate these themes a little bit later too, but rather it's not just the number of procedures, multimodality treatment of complex diseases, just like the question that was asked about multidisciplinary cancer conference to Dr. Singh. This is what we're really looking at. And lastly, looking at data. So you have to look at the outcomes too. So in this study, they was using a Delphi technique. They looked at 20 countries in both North America and Europe, and that they got some input from the thought leaders there. And really what we see is that only 65% of the countries in North America and Europe that were surveyed had minimum volumes. And you can see just the range of volumes there. I've just circled for pancreatectomy. Some of them are not reported, but in Canada, which I'm going to talk about in just a minute, where I was previously a health policy maker, we had 20 pancreatectomies per year, and that you can see in some other regions, not only the volumes are slightly different, but also how they were enforced were slightly different. And I'm going to get back to that a little bit. Unfortunately, we've talked a lot about how volumes are important. We haven't been good at making it happen. As well as part of the Delphi, they actually looked at obstacles to centralization. So those of you out there who want or interested in centralization or in charge of a jurisdiction or a country where you want to centralize, these are the things you have to tackle. And each one of these things actually could probably take a lifetime to fix. But really, you're talking about different obstacles at the level of the healthcare provider. That can be both, that is at the institutional level when we're thinking about this particular question. You don't have the infrastructure to do it. You don't have the people. You don't have specialized pancreatic surgeons necessarily. It can they can have problems with wait times and access. You can have at the level of the patient, and we talk about resistance to travel, resistance to not being actually in their home. They want to be close to home. At the level of the payer, that's insurance and government. And as well, there is quite a bit, there are political stakeholders that make it challenging because they don't want their local hospital to be closed. And these can be insurmountable at times. So if you're thinking about centralization, you have to think, well, these are the key things that you want to address: how to centralize, what to centralize, which models that you've heard of may or may not work for you. And also, I think we need to think a little bit about what alternatives they may be to centralization or should be done in tandem with centralization. So the other way to think about it, and a lot of the barriers I just showed fit into this concept of the iron triangle of healthcare, which is used in the United States, where when you try to, improve cost, improve quality, improve access, one of the points of the triangle, you necessarily have to compromise on the others. So really, when we think about the obstacles we see, we address some of these issues, and you can just see a sampling of how the different stakeholders feed into this iron triangle. So here we are. We're talking about this today, as policymakers, as professional associations, but we have to recognize that access and costs are axes that are important that we have to take in line and incorporate in any centralization considerations. So just to drill down a little bit about what countries have put in minimum standards and how have they been both established and enforced. I think this is very interesting, and you might look at your own jurisdictions to see whether you have some of that infrastructure. You can see that in Germany it was based on legislative policy. In Canada, we took a look at, we had professional input and very key clinical leadership. I think that might be one of the ways to success. Similarly, that's what they've done in the Netherlands, who also very successfully ran centralized pancreas surgery. And then similar to Switzerland and Austria, really they've been done by sort of top-down legislation. Everybody has tried to do this for a long time, so this is something that takes a long time to accomplish. And you can see that nothing is based on one study. This is evidence-informed, right? So we take that evidence and information, and then we come up with a normative standard. Everyone has used the same normative standards to determine what we ought to do. And then some of the other issues in terms of just the nuts and bolts of how it gets both enforced and how we established volume are there. So this is actually a good paper if you're thinking about trying to standardize in your jurisdiction. I'm actually going to take the opportunity to discuss Canada a little bit because that's where my professional work in this area has been. So I'm going to tell this story about centralization of pancreatectomy in Canada. So actually it's not all of Canada. Canada has 35 million people, but it's really in Ontario, Canada. And Ontario, Canada, just to let you know, is a single province, the largest province in Canada. 14 million people, has greater than greater than 1 million square kilometers, has 14 regional cancer centers and 151 acute adult hospitals. The insurance system is actually a single-payer insurance, so it's not a public system the way the NHS is. All healthcare delivery is private, not for profit, and that as a physician and a surgeon in Canada, you're actually a fee-for-service private contractor. And I had the opportunity when I was in Canada to work as the lead of this quality and health knowledge transfer of Cancer Care Ontario, and it was my portfolio was to regionalize and to maintain regionalized networks that were in place for complex cancer surgery. So that was the role. Cancer Care Ontario is a non-governmental agency. We oversaw all of the cancer care delivery in the province of Ontario. In my portfolio team, and we looked at access to care. We funded institutions directly, and within that, and I think this is also important when you're thinking about regionalization, it's not just about regionalization, which we did for HPB, thoracics, complex head and neck and gynae oncology, but also these other components are very important for success. Improvements in processes of care for cancer and being able to report high fidelity metrics of quality. So, and the one other secret is that we actually have comprehensive administrative data on over 98% of the healthcare work. So I think that makes it easy, and I think high quality data is very important if you intend to centralize. We used a very formal system where we looked at the quality of healthcare using the Donabedian model, which many of you are familiar with, which looks at structures of care, infrastructure, human resources, what your ICU looks like, when your OR is available. We also look at processes of care and outcomes of care, and regionalization really squarely looks at the structures of care. We then formed, and actually this was with my predecessor, which many of you know, Dr. Bernard Langer, who recently passed away. He was really the person who drove this regionalization process. He first assembled an expert panel. You got to get the evidence. You have to be able to convince people. You have to be able to tell the story of why centralization is important. So he collected the best evidence with a systematic review. He got early and wide stakeholder input. So it's not just a bunch of surgeons sitting in a room thinking it's a good idea. You have to get all the clinicians, medical oncologists, surgeons, pathologists, GI. You have to get the administration, local within your hospital, region within your region, the ministry, the payer. You have to get them all in a room and look at the evidence and interpret the evidence. And so with that, they come up with standards, and the standards include, and you can see a lot of these things here, not just surgeons, not just the hospitals. The hospitals had to have a clearly defined program. They had to have a complete range of multidisciplinary staff. They have to have support services, ICU, 24-hour endoscopy access. There was a volume target of 20 major pancreatectomies a year, but really was a composite target because it was 50 major HPV cases a year, which could be either all rest of them pancreas or could be liver. We had benchmarks of what we expected for mortality, and that, and you can see many of these elements are what allows people in these institutions to rescue patients, the failure of rescue concept. And this was initially released in 2016, and actually we re-updated it in 2015 as well. So it's important to demonstrate transparently the evidence and how you came to these normative conclusions and normative recommendations. As part of the implementation, we sent out the activities, so we basically looked and said, well, this is what's happening now, okay? We then asked institutions to then put together a package saying that they're interested in setting up a new center. We show them their market share, what they can repatriate, where the opportunity to repatriate, so do patients in their zone was. We then we ask them to see, if they don't have two surgeons, they have to tell us they're gonna hire a surgeon. This is what the surgeon, he or she's gonna do. This is how we're gonna repatriate our patients. So a really active plan. Then at Cancer Care Ontario, we would review the plans and approve them and then accredit them as a center of excellence with the understanding there's gonna be annual monitoring of performance at all times. And we were able, with that kind of iterative, active approach, to go from 68 institutions to 10 HPV centers of excellence. And you can see what the volumes look like there. You can see, and this is courtesy of CCO, Cancer Care Ontario, is that we started pretty well. Actually, it was fairly regionalized anyways, but now virtually 100% of all cases for HPV pancreas are done in the high volume centers, and over 90% of the livers are done in high volume centers. So really been very successful year over year, achieving these volumes and giving the patients good outcomes. And then we report it. So this was, it's very important. You can't just implement and say people are gonna do it and then ignore them. You actually have to actively manage them every year. Everyone's always trying to escape and do a case, I can tell you that. And so what we do is we do a lot of monitoring. We do some compliance. The compliance is done through public reporting. If there is a center that does more than 5 cases, we actually re-audit. We ask them to pull their cases. We meet with them and ask them, are you interested in being a center? If not, what can we do to help you? So there was public reporting. There was active performance management. We report these, at Cancer and Care, they now report these metrics every 2 years, case volume, mortality, and reoperations. And they were kind enough to resend me the most recent session. Is that if you look here in Ontario, 90-day mortality rates, high fidelity data, nearly 100% capture, you can see that the 90-day mortality is 2% at 90 days. It's pretty good for 14 million patients, and that we can report the reoperative rate at about 4%. So this is the kind of data that people expect to see and need to see for them to continue to believe in centralization, for it to continue to work. Now, I'm not going to talk too much today, but it's really important that you have funding levers to help reinforce, or I would say encourage, participation, right? Because it's very hard to take money away, but it's maybe a little bit easier to not give money, extra money, incentive money. So I think funding levers, and you guys can talk to me offline if you're interested, how those might work, but those are important as well. So really using high quality, complete data is essential. You have to use the data actively for both performance management, and I would recommend for public reporting. Hopefully you can generate the data in a way that the local institution can actually regenerate it themselves. Because you give them the data and they say, we don't believe you. I'm pretty sure no one died in our hospital last year. So they have to be able to regenerate the data and look at it, and you have to actively work with them to help them to review it. Audits, we recommend routinely commission them and work with people to look at it and try to help them improve. And this is really important. The role for centralization is to facilitate it. If they're having struggles, you can't close them down, particularly in the public system. Have to help people get better. So in addition to just reporting and having centers, we want to work with them to get better when possible. We were implementing best practice guidelines for perioperative care. We have to improve standards of care as well in tandem with centralization. So really, our experience in Ontario was that it was gradual. It took over a decade for this to be fully implemented. It was really successful with an active plan and with multiple tools to implement successfully. I think it's incredibly important to have clinical leadership, professional association leadership to get successful adoption, to be able to explain why we're doing it, to basically get buy-in, and that high quality data and continuous monitoring is essential. And really, and this is advice. I don't think that this is all published very well, but basically that I would suggest that you look for trying to bring institutions that are close to a threshold over the threshold. So aim for modest volume targets, try to be inclusive in your strategy. If you've got institutions that are doing 17 cases a year, maybe you can get them up to 20 cases up this year and maybe 30 cases up in 5 years and maybe 50. So try to grow rather than send everything I think hyper-centralization will run into issues with some of the other stakeholders. If you look at Italy, in Italy they like to they're also working on centralizing, and one of the numbers I looked at, if you centralize all surgery for pancreas cancer to 2 institutions in all of Italy, you'll save 87 deaths per year. Okay, that's not a lot. That's a lot of, that's a lot of hyper-regionalization. It's not a lot of deaths. Maybe you can do a little bit better with more modest goals. So I think that there's different ways to do it, but I think successful strategies are a balance of other stakeholders and professional stakeholders like ourselves. So maybe a modest target strategy, composite volumes. I would recommend that might be the way to go. So if you want to centralize in your region, I guess, I told the story of Ontario. Most of that's not relevant for many of you, many of us in America. That is also very challenging. So what can you do? I think what's important, and hopefully you heard some of it come through, is that you have to have infrastructure to help you centralize. It's not enough to just say you should do it. You have to have formal implementation science methods. So this is, if you describe it as a knowledge to action gap, looking at the implementation science literature to help you centralize, I think is important. You have to identify the evidence, as I showed, you have to then find important key opinion leaders, which for us as clinical leaders, to convey the message, convey it in a diplomatic and a democratic way. You have to provide the tools to allow people to centralize. That includes helping them with their own data, helping them to interpret their data, and helping them be successful if they're not yet successful then. I cannot reemphasize, I think I've said 100 times today, that high quality data is really important, because if the conversation is always about the quality of the data, you never move forward from there, right? And some kind of reinforcement data or enforcement tools, I should say, are really important. They can be things like financial, they can be public reporting, they can be professional encouragement. But I think that that's also, you will not be successful with centralization without some of these infrastructural tools. Now, the other thing is to recognize is that there are real limits to centralization, and that's important to keep in mind. Successful centralization may, I should say, perhaps always compromise another component of what we would consider quality or value, either cost or access. When you have stakeholder concerns saying they don't want to close their local hospital or they want to keep a hospital open in a region, you have to recognize those are actually very legitimate concerns, and you have to incorporate their concerns somehow in your centralization plan. Those can be geopolitical concerns, cost concerns, or logistic considerations. And then there are other things that I think are important, is that other things have improved since the volume outcome data have come out. And so the volume outcome relationship may be less pronounced now than it was 25 years ago. There's much better specialist training. Part of what the IHPBA and the HPBA does is train experts in HPB surgery. So the capacity for high quality surgery in the community, in the non-academic, in this lower volume, modest volume centers, much higher than it ever was. Processes of care, multidisciplinary cancer conferences, telemedicine initiatives that decrease barriers to access of care. All of these other things have also improved in tandem with our challenge of trying to centralize. And those can be all incorporated as independent quality initiatives. And I think in some countries where centralization is nowhere close or the infrastructure doesn't exist for it now, you should look for some alternative or what I call complementary strategies for quality. So the American College of Surgeons has a self-identified Center of Excellent Accreditation model. That's a little bit of an alternative. It's like a where the institutions decide that they want to be centers of excellence and go through a verification process to verify their quality. I think that's an option to top-down centralization. In the private system, centralization, and probably the biggest opportunity may be to centralize in the US in hospital systems. So Kaiser Permanente hospital system that is in America has 12 million patients. That's almost the number of people in Ontario. That's bigger than Denmark. It's, so there's opportunities in private systems to do some of the centralization. They have a lot of the infrastructure already that's necessary. And I think that other kinds of quality initiatives that really get to the heart of what volume was a surrogate for. Best practice, standardized practices are another way that we can work that can be used to centralize as well. So I just want to end on that and really just say I hope it stimulates some ideas, and I'd really like to get some questions about whether or not it's been successful centralization for you, what the challenges have been. Thank you.
Thank you very much. That was really a wonderful overview, and we'll welcome questions from the floor.
Amr Zurich at Pittsburgh. That was fantastic. Really shows your command of the field, actually, Alice. Very well done. My question was, obviously the challenges here being a non-single payer system, but when you went from 68 centers to 10 centers that do HPB, there must be an opportunity cost for those centers to not do HPB, and there's a give and take to that equation. Was there any sort of decentralization of other cases to those centers as a kind of remuneration or some sort of kind of a carrot to give?
Yeah, so that's a really good question. You can't just take from everywhere else and give nothing back. So one of the things at Cancer Care and Chair we did is we didn't talk, for complex cancer surgery, we actually brought the patient to the institution. For surgery that could be done close to home, we brought the quality to the patients, right? Because and that's breast, that's prostate, that's colorectal. So you're right, what you want to do is give the opportunity for the institutions to be good at something that just doesn't have to be complex cancer surgery for the moment. And that's part of the negotiation, and it's part of, trying to fill all the needs for a healthcare system.
Next in the center here.
Hi, thank you so much for your talk. I'm Rebecca Platoff, surgery resident at Cooper Hospital in Camden, New Jersey. My question for you is about the kind of pushback that you received, maybe from specific providers or institutions more broadly. I would imagine that people might have strong opinions about being, mandated which cases they should do and not do, and maybe talk a little about what kind of pushback you got and strategies for getting people on board that were initially in opposition.
Yeah, so of course there's always pushback. The easiest one is they always say the data is wrong, okay? So the most important thing is to make sure that your data is right, or as right as it can be for the needs. So that's challenging. I think one really important thing is I do think physicians are very driven by good quality data, and every physician wants to do a good job. So part of it is to try to help them understand how they can do a good job, and if it doesn't happen to be pancreatectomies, for this indication, perhaps it can be another area, and I think this goes back to Dr. Zurgat's question. If your institution isn't a high-volume pancreas center, maybe we can talk about it being a high-volume maternity center or a trauma center or a vascular center. So I do think trying to, balance these needs is really important, but the biggest pushback is the data. That's why the data quality has to be good, and if it's not, and people say administrative data is not the same thing as clinical data, but I think you have to explain to them what the goal is. The goal is to get a signal-to-noise ratio rather than, knowing exactly what you did Tuesday in 2021, right?
Thank you.
Hi, my name is Kurosh Kujuria. I happen to be in charge of HPV surgery for Northern California Kaiser Permanente. We were able to centralize 100% our cases over a course of 3 years. The challenge we have is actually not with surgery, but it's with oncology. And I was wondering if you have any comment about that, because a lot of our patients are getting their surgery at our centers, but they go back to their local oncologist. And then you get this mix of oncologists who are not very aggressive. Some oncologists have no sort of hesitation to go on Gembraxane and just leave the patient there. Some oncologists are pushing for more aggressive chemotherapy. And then that's why my question for you is, in your Ontario experience, was this only for surgical part of pancreas cancer care, or for all parts of pancreas cancer care?
Good, that's a really good question, and I think what you speak to is one of the hidden issues with centralization, that patients get fragmented care. They go to high volume centers for the pancreas surgery and then they disappear. Whether or not they need to get readmitted, that's an issue, but also their preoperative and postoperative care and cancer-related care may be different. This initiative at Cancer Care Ontario was for pancreatectomy, so it was a surgically led initiative. However, as part of the standard, you can see that it really had to do with having a multidisciplinary approach. We actually had medical oncologists as part of the stakeholder group to review the evidence, but we didn't incorporate them into the volume outcome calculation. It's very interesting because not a lot of data has been published on volume outcomes in radiation oncology, which is very similar to surgery in terms of quality issues, and medical oncology. But you know, I think if we can fix centralization for pancreatectomy for everyone, probably the next level would be to talk about medical oncology. MCCs, multidisciplinary cancer conferences, can fix some of that or can improve some of that.
I might give the Irish take on that most recent point. So we centralised pancreas cancer in 2011, and all of a sudden we went from 4 or 5 units doing it to 1 unit, doing it for the whole country, a population of 5 million, and overnight that unit was doing 120 pancreas resections per year. Very good surgical successful outcomes and all the rest, and that went on from there. But what we're finding recently with what's becoming more and more common, neoadjuvant approach, we hadn't centralized that, and we're finding a striking difference in the people who make it to surgery having had their neoadjuvant with us versus who have their neoadjuvant in outside hospitals. And that's something we're going to have to address, and it's not going to be easy to address because we're going to have the exact same pushback as we had 10 years ago on the surgical side, but it's becoming, there's a twofold difference, so we have to do something about it here.
The rising tide floats all boats, hopefully, right? Like,
Exactly.
even though there's still a range, hopefully everybody will get a bit better. And also what I said earlier about having modest volumes, having more centers with modest volumes is probably a better way to, you know, get the capacity out there rather than hyper-centralization.
One final question.
Thanks. Paresh Shah, NYU. Alice, really great work. You know, what you've done in Ontario is a model for a lot of us. But there are some real challenges with this, and I would submit to you a couple of questions to challenge the concept. So in the American context, centralization has challenging connotations, right? So concentration may be argued over centralization, just in the political climate. But my real question is this. While we're talking about this from a surgical perspective, cancer care and complex medical care, as it's evolving, is really, shouldn't it be more about bringing that quality to the patient rather than bringing the patient to the quality? You mentioned that in your talk a little bit. And the examples we've talked about in the last 30 seconds of medical oncology being different. What can we do looking forward to bring the quality to the patient? The reality of what you can achieve in Ontario or within the Kaiser system or within the country of Ireland are great examples in those small microcosms, but they're difficult to generalize. So how do we extrapolate to what the future will bring, both with technology, with common understanding, to be better able to bring the quality to the patient rather than bringing the patient to us?
So, you know, I thank you for the question. I think it's very important, I do not, and I think anybody here who's not American or isn't from China or India, big countries, probably doesn't appreciate how much complexity scale brings, right? And I think that's one thing I didn't appreciate when I first came here. I think that I tell patients don't want to come to New York to Manhattan for their surgery, but I say, well, you come for a baseball game. So why don't you come for your Whipple, and we'll do everything else as close to home as possible. So there are different ways to get around that, particularly with telemedicine. So some of our outreach that we can do, some of the operative assessment, preoperative assessment, postoperative assessment can be done closer to home. Whether or not in the future we'll be able to truly bring all complex cancer surgery quality closer to the patient, the answer is perhaps. I don't think we're there yet. I do think some of the volume outcome relationships have been mitigated as we all get better. Quality has gotten better since all of this original data was done in the early 2000s, late 1999s, but it's not there yet. So perhaps now we can still bring patients for surgery. In the future, there may be enough well-trained surgical oncology fellows that we're all training and HPB fellows that are able to do it closer to home, but the question is whether we can do it there at this time. I don't think so. I think one last thing I'd like to say is that it doesn't have to do with the technical surgery that we do. I'll give you an example. We in Ontario, we're trying to develop centers of excellence for microvascular reconstruction, breast reconstruction. Very technical surgery, you need a microscope. Turns out you only need to do about 20 cases per year. We can do that because there's lots of volume for that in the community. It doesn't need to be an academic center. You can do excellent, high-quality surgery in the community. You just have to be able to, have the local patients to do it, and you have to have the right infrastructure for it. So I think that's one thing that sometimes is a myth. They don't have to come to a high-volume center because we're better surgeons. It's really not about that. It's about just trying to consolidate. Is that a better word? Consolidate? Rather than centralize or regionalize. We need to consolidate services in a way that makes sense.
Dr. Wei, that really was a wonderful overview. Unfortunately, we are out of time, so we'll close this session, but thank you.
Thanks.
Thank you again.
See you later.
Should we call them out? One by one or all on the panel? One by one. First speakers. Do you want to open? Should I open? You open. Good afternoon. So the session we've all been waiting for, a plethora on hilar cholangiocarcinoma. My name is Geert Casimir. I'm a surgeon from Amsterdam, the Netherlands. I'm a transplant surgeon, that's my disclosure, but my hobby is hilar cholangiocarcinomas. My dear colleague, we are co-hosting it together, and a really interesting session, although we are a little bit out of time. The first speaker I would like to pronounce Dr. Tomoki Abata from Japan. Is he already in? I didn't see him. If not, Karen Brown. Oh, we have
Oh, it's a video? Okay. Shall we start? Is he live or do we have a video from him? Play the video.
Play the video.
Thank you.
Good afternoon, everyone. I'm Tomoki Ebata from Nagoya University Hospital. I'm very honored and delighted for giving me a chance to talk here. And I deeply appreciate scientific committee members, and I'm sorry I joined the meeting virtually. My allocated topic is about tumor classification for perihilar cholangiocarcinoma. I have no COI about this topic. First, I would like to check again the aim and scope of tumor classification. Tumor classification categorizes local tumor spread by a specific rule, and the rule is on the basis of anatomic approach at the present. And it may predict resectability and survival. And the tumor classification should be used both in the clinical and pathologic setting. The AGCC clearly states staging must be given independently at initial presentation to make a therapeutic decision, and also after resection to predict survival probability. Tumor classification should apply simple and easy rule for usability at all corners in the world. But recently, more personalized approach is recommended. This direction partly conflicts to some important features of the TIP classifications. There are three approaches for tumor classifications. Anatomic layer measure the depth and size or length. How do we express local tumor extent in this nodular tumor? The later stage is categorized by the anatomic layer of invasion. In this case, beyond the wall, but not invade the adjacent right hepatic artery. So this is located at the PT2 tumors. Alternatively, we can measure distance between the normal naive mucosa and the top of the infiltrations. Or we can measure also thickness of invasive cancer component. In addition, lateral length or tumor size might be potential another measures. Please note that these approaches can be used for tumor classification, but only in the pathologically. At present, we have four major classification systems specialized for perihelial cholangiocarcinoma. Initial form of UCCT classification was proposed in 1968, over half century ago. Because this system has been periodically revised until today, so we use this system as a global classification at the present. Besides, bismuth system, Brungat system, and recent depth-based T system are present. Now I talk about these systems. First, I talk about bismuth system, a very common classification to describe the extent of biliary invasion from type 1 to type 4. Initially, Professor Bismuth classified this system using an intraoperative cholangiogram to choose the optimal site for palliative biliodigestive anastomosis. Now we classify bismuth type by CT, MRI, and or endoscopic cholangiograms as the initial presentations. Because Professor Bismuth linked this system to surgical strategy in 1992. For instance, type 4 was a locally advanced and resectable disease. So, at present, quite a few surgeons still follow the bismuth guide. On the other hand, we can find some drawbacks in bismuth system. It's difficult to evaluate in histopathology. Pre-surgical use only is a major problem. It disregards anatomic variations of the biliary systems, and most importantly, bismuth type itself has no survival impact. This figure shows survivors for 392 patients who underwent M0 and 0R0 resection. Comparable survivors were observed about 60% at 5 years. So I think the bismuth system is a very excellent notation system, but not staging system. The current HCCT system is shown here. This is an anatomic layer-based T classification from TIS carcinoma inside to ductal wall invasion behind the wall and the liver invasion and the vascular invasion. So 5-year survival significantly reduced with advancing tumor classifications. 100% in TIS tumor and 22% in PD4 tumor. This pathologic T classification to work well as prognostic indicator. The third one is Brunga T system that combines portal vein invasion and bismuth type as T determinant. This system is used clinically to make a surgical decision, so mainly by surgeons. It may be widely used in the West, but rarely used in Japan. Our cohort, Nagoya cohort, reconfirms the good stratificating ability of preoperative Brunga T stage. Again, pre-surgical use only is a sole problem against tumor classifications. The fourth classification is based on a series of pathologic studies that are conducted by Professor Hong, a Korean pathologist. He constantly proposed the utility of measured depths alternative to conventional layer-based approach. This is a method of measurement of DOI, depth of tumor invasion. In response to this, the agency changed the T-system drastically in the latest editions. T-system for distal cholangiocarcinoma is now based on the measured depth of invasion. But T-system for higher tumor is still layer-based approach due to limited available information. These two figures show survival stratified according to depth of invasion that were measured histologically. In the left are used study. The cohort was divided into two groups with a cutoff value of 5 mm, and the two groups had significantly different survival. In the right, a Japanese study. The cohort was divided into 4 groups with cutoff values of 1, 5, 8 millimeters. Survival probability were worse with increase of depth of invasions. However, some pairwise comparisons failed to show significance. We should caution that depth of invasion is not a clinical measure but a pathologic one. So what's the best local tumor classification in the clinical pre-treatment setting? Using 702 cohort, resectability and survival were compared among the 4. The method was radiologically measured by CT image, and the cohort was divided into 4 groups as shown here. Resectability rate significantly reduced with increase of T stage, except for bismuth type. Earlier under the curve demonstrated that the AGCC system shows the best relation among the 4 systems. Resectability rate was as high as 100% in T1 tumor, while it stepwisely down to 50% in T4 tumors. In all systems, survival stepwise declined with increasing T stage. Of the 4, only AGCC system showed a significant difference between all pairwise comparisons. The 4 systems had the C statistics of around 0.6, but the AGCC showed the highest value. So my conclusion is the present AGCC USACT classification is the best for tumor classifications. Thank you for your attention.
It is impossible to have discussion with this speaker, but we would like to have the discussion at the end of all the presentations. So, Karen, can I challenge you to tell us everything about invasive pre-op techniques, please?
It's nice to see some diehards here on the last afternoon of the last day when the sun is shining outside, so thank you all for being here. I'm very excited to be able to talk to you about biliary interventions in cholangiocarcinoma. I'd like to thank the meeting organizers for inviting me. Those are my disclosures, nothing relevant to this. Before I really get started, I'd like to just cover some terminology I'm going to use during the talk. As I'm sure you all know, there are covered and uncovered self-expanding metallic stents. As an aside, there has yet to be any evidence supporting the use of covered stents in the biliary tree other than the added expense. They are retrievable, so you can take them out, and that may be important in certain clinical situations. There are 3 kinds of biliary drains that we put in. I'm sure most of you are familiar with the external biliary drain, which is shown on the, where can I point? Over here. So the drain enters the liver percutaneously. It terminates above the obstruction. In this case, I'm showing a low bile duct obstruction, but same idea for a hilar. There are side holes above the obstruction, and the catheter has to be drained to a bag to the outside world, otherwise the patient will not be drained. An internal external catheter typically goes into the biliary tree, beyond the obstruction, terminates in the duodenum or the small bowel. The advantage of that catheter is it can be capped so the patient doesn't have a bag, and it can drain internally. There's also what I like to call a functional internal external biliary drain, and this is relevant for patients with high bile duct obstruction, for instance with perihilar cholangiocarcinoma. And in this case, the catheter enters the bile duct, it crosses the obstruction, and it terminates in the common bile duct above the ampulla. The advantage of this is that the biliary tree does not get contaminated with enteric contents, and yet the catheter can be capped and the patient can be drained internally. I'm really going to focus today a lot on primary biliary stenting because I think that that's very relevant for patients with hilar cholangiocarcinoma, obviously those that are not resectable, but we'll talk a little bit about preoperative drainage as well. So why not place percutaneous stents primarily? A few decades ago, I used to say 2 decades ago, then it became 3 decades ago, and maybe now it's 4 decades ago, but we didn't have self-expanding metallic stents. So the only way to really easily and safely put in a stent was endoscopically. If you tried to put it in percutaneously, you had to make a pretty big hole in the liver. But now we have this self-expanding stents. There's no reason that interventional radiologists can't put them in primarily. None of the patients, I'm sure you all know, there are no patient that says, oh, I hope I never have to lose this drain because I really like it. Even if the stent occludes in a couple of months, which it won't, the patient still gets 2 months without a catheter. In high bile duct obstruction, when the stent is kept above the ampulla, it keeps the system sterile, or it keeps the system from being contaminated by enteric material. The patient has less visits, lower radiation exposure, lower cost, and there's also data to suggest that there's a lower risk of bleeding when you primarily stent than when you put in a catheter. When is a primary stent indicated? Well, in malignant low bile duct obstruction, always, because as long as you put in a short stent, it comes out with a surgical specimen, and I've been told that this does not impede the resection at all. In malignant high bile duct obstruction, if the patient's potentially a surgical candidate, we prefer putting in the functional internal external drain, and patients who are not resectable should have primary stents placed. So low bile duct obstruction is only relevant in this context in terms of patients who have a distal bile duct cancer. And in those patients, anyone with low bile duct obstruction, whether it's distal bile duct or pancreas or whatever it might be, should primarily be managed endoscopically in patients with normal gastroduodenal anatomy. The percutaneous approach is reserved for patients who have altered anatomy or where endoscopic approach has failed. In either case, the stent crosses the ampulla, so in both cases, enteric material can enter the biliary tree. There's no reason to use one or over the other. I always say that low bile duct obstruction is easy for the interventional radiologist. You can approach it wherever you want, the left side, the right side. In this case, this is a case I got from an outside hospital, and it just goes to show you can really do it anyway. This catheter comes right down the umbilical fissure, directly enters the common duct, and then terminates in the duodenum. I can't even imagine how this was done. This is the cholangiogram from the same patient. It seems like it would be incredibly technically challenging to do it that way, not to mention very inadvisable given all the other structures that one encounters in the hepatic hilus. At any rate, this patient had leaking from the catheter because there were only a couple of side holes above the obstruction, but his bilirubin was normal, so you can kind of do low bile duct obstruction however you want to do it. This is an example of primary stent placement in a patient with low bile duct obstruction. It happens to be a patient with pancreas cancer, but it makes the point. Once the cholangiogram is performed, we define the length of obstruction. We make sure that the duodenum looks normal and has normal motility, and then put in the stent. You notice when the stent is first deployed, it's narrowed. They do self-expand, as the title suggests, as the name of the stent suggests, but in the olden days, like a couple of decades ago, we didn't have access to anesthesia, and dilating these is pretty painful, so what we used to do is just leave the stent like this and bring the patient back the next day, at which point the stent is expanded by itself. You can tell it's working before you inject contrast because you can see gas in the bile ducts. but we would then inject and demonstrate that the contrast flowed freely into the duodenum and take out the catheter and plug the track. High bile duct obstruction, on the other hand, is a totally different story, and particularly when you're talking about hilar cholangiocarcinoma. In my opinion, this belongs to the interventional radiologist and should not be approached endoscopically. The reason is that there are many more considerations for high bile duct obstruction, particularly malignant high bile duct obstruction. First of all, is the patient a surgical candidate or not? If the patient is a surgical candidate, they may not need biliary drainage. If they are, it's important for the interventional radiologist to know what the functional liver remnant is. If they are a surgical candidate, do they need a preoperative drainage? Well, I'm sure most of you know that seems to be a subject that's been debated for years, and I will leave that decision up to you. In a palliative setting, if the idea is to treat pruritus, draining one segment of the liver can relieve the pruritus. On the other hand, if you're draining the patient to lower the bilirubin for chemotherapy, it's likely that more liver parenchyma will need to be drained in order to be successful. What's the status of the portal venous system? If the portal vein to the liver parenchyma is occluded, then that part of the liver is essentially not functional. So putting a catheter in the biliary tree is not going to solve any problem for the patient. What's the degree of isolation? Degree of isolation, I refer to how high the tumor has climbed up the biliary tree above the hepatic hilus. Anything above the hepatic hilus results in isolation. As the tumor extends further into the intrahepatic bile ducts, you may have sectoral or even segmental isolation. The idea, though, is to target the liver that's functional and try and maximize the amount of functional parenchyma that's drained. The bismuth classification I don't need to explain to any of you, and it's already been talked about in the last talk. Suffice it to say that anything above bismuth 1 is going to result in isolation, and that's where targeting becomes particularly important. In my opinion, ERCP is the enemy of high bile duct obstruction. Why is that? Well, because the first thing that happens with ERCP is we get a sphincterotomy. After the sphincterotomy, we get injection of contrast material and bacteria into the biliary tree. Once there's a sphincterotomy, the function of the sphincter is forever impaired, and I think that's a very bad thing if you're trying to avoid patients getting cholangitis. So what evidence do we have for this? I'm going to start out by showing you a couple cases of why I think endoscopic stent placement in cholangiocarcinoma is a problem. So this is the first case. This is a patient who presented with hilar obstruction, presumed cholangiocarcinoma, knee-jerk reaction, patient needs an ERCP and a stent. The stent was placed in the right side, but I'm sure, again, you all know that when they do ERCP, the patient isn't supine on the table. They're in some sort of decubitus position. And it can be very difficult to tell, even for the endoscopist, what part of the biliary tree they're in. When the patient's jaundice did not resolve, a CT was performed, and I think you can see the stent is draining only segment 4, which gives you a little clue as to why the patient is still jaundiced. Here's another case. This came from an outside hospital when I was at Memorial. Patient had an MRCP that demonstrates atrophy of the left liver with crowded, dilated bile ducts. This is an image from the ERCP. The cannula is deep in the left hepatic duct. Segment 2, 3, and 4 are all isolated. The stent was placed. The patient's jaundice did not resolve. The patient developed cholangitis and presented to our hospital with cholangitis. This is a patient's image from the intervention. Sorry. There's no way of knowing which side of the liver is contaminated. Probably, you know the left one is because that's where the stent is, but the right is probably contaminated as well from injection of the bacteria. So we decided we needed, in order to relieve the cholangitis, to provide drainage to both sides. So we entered the right, put the catheter over to the left side, left an external drain until the patient cooled down, and then we brought them back so that they could have a better drainage situation. This is my favorite case. This came also from an outside hospital. I think you can all appreciate that the left liver is the size of a peanut, but there was endoscopic stent placement into the left bile ducts and then out of the liver so that the patient presented with sepsis and a perihepatic collection. The first step, given the patient was septic, was to drain the perihepatic collection. The patient was brought back 2 weeks later once they were out of the ICU, so that was 2 weeks in the ICU. They had had this tenuous right-sided external drain placed, and that was used for access to the right biliary tree. And the patient was then given an internal-external biliary drain. The left-sided drain remained in place. Ultimately, it stopped draining bile. And the patient was brought back, and that internal-external catheter was converted to a stent. So much as we were able to salvage this situation for the patient who almost died in the ICU, it was 12 weeks from the time that we met her, and all that the endoscopic stent did for her was buy her some time in the unit and delay her treatment and cause severe debilitation. So this is a study that one of my late colleagues, Dr. Raymond Thornton, put together. It's a cohort study where he looked at 148 patients who had underwent biliary drainage with the indication of lowering the bilirubin for treatment. Now, this included a mixture of high and low bile duct obstruction patients. And what he found in this study was that the likelihood of achieving that at 100 days occurred in 1/3 of the patients. So 50% of the patients did get a bilirubin of less than 2, but the idea that you're going to do some sort of intervention in a patient with bile duct obstruction, necessarily normalize their bilirubin, is not one that we should adopt without further investigation or thought. When he looked at the factors that were associated with achieving a normal bilirubin, one of the things that was identified, which makes sense, is that the patient had to have a significant amount of the liver drained. So if you had 100% of the liver drained, as you can in low bile duct obstruction, the majority of the patients achieved this goal. But in patients with high bile duct obstruction, as you were able to drain less and less of the liver, the chances of achieving that were less. This is another paper that Dr. Thornton put together on 71 patients. When we started to put primary stents in back in 2011, our process at Memorial always was, if you're going to do something new, you got to look at it and see if it's really working. And he found that 71 patients with primary stents, the majority of them, 97%, were catheter-free at death, although 7 of the patients did require reintervention. The 2 patients that weren't were probably patients with low bile duct obstruction who had duodenal motility disorders, and they ended up needing to have external drains. More recently, we looked at all of the patients that presented to Memorial with a diagnosis of hilar cholangiocarcinoma, and we looked at the patients who had endoscopic stents in at the time of placement. Almost 40% of patients who required reintervention who had endoscopic stents, in almost half of those cases, the indication was cholangitis. None of 33 patients who did not have a previous stent ever developed cholangitis. There's a patient from the Netherlands that also reported that 56% of patients with perihilar cholangio who had previous endoscopic stents placed required additional percutaneous intervention. And they also noted that 0 of 58 patients without preoperative intervention developed cholangitis. So I think what this tells us is that it's not a good thing to put enteric contents into the biliary tree. It's not a good thing to inject bacteria into the biliary tree, into places that may not be drained but be contaminated. Alternatively, these patients should be, I would recommend, treated percutaneously. So this is an example of what you can do with percutaneous approach. This is an 88-year-old who was not resectable, presented with a small hilar tumor that was isolating the right and left side. I think you can appreciate there's loss of volume on the left with crowded, dilated bile ducts, a sign of likely involvement of the left portal vein, even though you don't see that on these particular images. This patient comes down, and what we do is on our initial cholangiogram, we identify the obstruction, the length, the extent of the obstruction. We make sure that there's evidence that the distal duct is normal. We then deploy the stent. We remove all of the devices, confirm the contrast material passes into the duodenum or small bowel, and at that point we remove the sheath and plug the track. So this is how these patients should be managed. This is how the patient looks 6 months later. You can see there's progressive atrophy on the left side, so that would not have contributed anything to her well-being should someone have erroneously stented into that part. The ducts on the right side are not dilated. The patient's bilirubin was 0.9, so the objective was achieved for this patient, and she had 0 catheter days. There was a consensus statement in 2013.
Karen, would you be so kind as to wrap up?
What?
Would you be so kind as to wrap up?
Yeah, I'm almost done. That recommended percutaneous approach for patients with high bile duct obstruction, but it doesn't seem as if this has necessarily penetrated into the Western world. So in summary, percutaneous approach is preferred for the targeting. The targeting can be accurate for the functional liver remnant and that part that has portal vein flow. We need to maximize drainage of the functional liver and avoids cholangitis. In the palliative setting, also primary stents, less bleeding and improved quality of life. And in preoperative setting, the functional internal external catheter.
Let me call upon Dr. John Primrose for the next talk, which he's going to talk to us about the need for multidisciplinary treatment in hyalocholangiocarcinoma. Dr. Primrose.
Right, okay. And do we have a pointer? That one. Oh yeah, it's great when everything comes together, isn't it? So, it's a great pleasure to be here. I'm pleased to have been invited to talk about an area that I'm really interested in, which is hyalocholangiocarcinoma. These are my disclosures, not as many as I would wish, but that's the way it is for surgeons, I'm afraid. I love operating on hyalocholangiocarcinoma. I think it's a really nice operation, particularly if it goes well. It's complex. It's an operation made for hepatobiliary surgeons. The reality is, however, that most patients do relapse and die. And so surgery in itself, even well performed, is not always the solution. In this talk, I want to show you some data from the BILCAP trial, amongst others. And just to go over it, this is a UK study, a randomized study in which capecitabine for 6 months was given following resection of hyalocholangiocarcinoma. And we showed there was a 14% benefit. And on the basis of this, both the ASCO and the ESMO guidelines currently recommend adjuvant capecitabine. Although I note that in the Netherlands this hasn't quite been put into place yet, but one hopes in time it will be.
We're always slow. We're always a little bit slow.
There is now a Japanese study, which I'll show you the results of in a moment, which actually confirms the utility of an oral fluoropyrimidine in this setting. So just to show you the survival curve from the latest update on the BILCAP trial, this is the outcome. It shows a modest but genuine benefit of oral capecitabine. And actually looking at this is the ASCOT trial, not published yet, but it was shown at ASCO GI, and you can see there's actually a more significant result using S1, which is a drug very similar to capecitabine. The other thing to say is that you notice that the survival in the Japanese study is much better than in the UK, but they are not clearly comparable populations. I'm sure we could debate that more. Now, I want to show you this. This is perhaps the most important slide I'm going to show you. You don't need to take a photograph of it. It is published online now in JCO. And this is the Cox's model that we produced for the BILCAP trial. And without going into the statistical methodology, what this is about is showing how each individual component or parameter performs in isolation. So it's corrected for everything else. So if you look just at the top there, you'll see the effect of capecitabine, hazard ratio 0.74, so hence benefit. If you look at the site of disease, there's really not very much difference. I suppose you could say the intrahepatics did a little worse, and the gallbladder and distal did a little better, but there's very little in it. resection margin absolutely matters, and there's a modest difference with respect to performance status. But the thing that we have never had reported before, as far as I'm aware, is sex. You can see if you're a woman and you develop hilar cholangiocarcinoma, and develop cholangiocarcinoma, you do much better than a man does. And you can see that the benefit of just being female is very similar to the benefit you get from adjuvant chemotherapy. Big effect of nodes, but we know that. A big effect of differentiation, we know that. But there's nothing we can do about any of these. That's just how the tumor is. Now, we did exploratory analysis looking at the different sites, and there's no statistical validity to any of this, but if you look at the perihilar, the lines don't really separate that much, whereas they tend to in the others. And so I guess there has to be some doubt as to how effective our adjuvant treatment is in this setting. This caused us to look a little bit at the R status. And what you can see here is that in perihilar cancer, there's quite a high incidence of R1. And I think any of us that do this know the reason for that. It can just be very difficult to get complete clearance. It's much worse than intrahepatic or gallbladder cancer. It's quite similar to the distal disease, but we all know about the arguments for R1 resection in Whipple, so I don't think we need to discuss that further. It got us thinking, though, could the R status be the reason that the effect of adjuvant chemotherapy in hilar cholangiocarcinoma seemed to be somewhat less? And so we looked at the R0 versus the R1 resections across the whole trial. We couldn't really just select for hilar. So just look at the end column here, okay? So if you had an R0 resection, 22% got local recurrence, 14% got 19% got local recurrence, 22% got distant recurrence as the initial presentation, 14% got both, and then 45 didn't get either. So there's quite a lot of systemic relapse, even in an R1. However, if you go to the R1 patient, certainly there's more local recurrence, but also the distant recurrence and the local and distant recurrence is very much more. And what I'm suggesting really here is that R1 is basically a surrogate for bad disease. And that, it may be that local treatments to try and reduce local recurrence may not actually be very effective. So I think we can say there's a clear indication for adjuvant chemotherapy everywhere in the world, including, I hope, the Netherlands. In perihilar cancer, I guess the data is not particularly clear. It'd be interesting to look at the Japanese data when it becomes available to look at this. R1 is certainly more common in intrahepatic, in perihilar cholangiocarcinoma, but the local recurrence may actually just be a surrogate for bad disease when you get systemic relapse. So, yeah, there's talk about IORT or SBRT, but I'm not absolutely convinced that that is going to be effective. But we'll talk about that a bit more in a moment. And maybe different approaches are needed, for instance, adjuvant, either adjuvant or neoadjuvant therapy. Now, the trial that followed BILCAP in Europe and Australasia is the Actica trial. As you see, it's recruited quite well despite the pandemic, and we're, I think, about 80 cases away from completing. And it may be that gemcitabine cisplatin is actually better than capecitabine, but we're actually not going to know that for a few years. There's big interest in immunotherapy, and the drug companies are just doing trials in just about every cancer they can get their hands on at the moment. And durvalumab, and usually it's called Durva because it's just easier to pronounce, is a PDL1 inhibitor. And in the phase 2 trials, it did seem to have some activity in cholangiocarcinoma. So it's been tested in a phase 3 trial against GEM-CIS alone in advanced and inoperable disease. And in fact, the results of the trial was presented at ASCO GI, and it's actually very interesting. There is a significant survival advantage to immunotherapy. And this is quite a typical curve that you see in patients who get immunotherapy. And the curves begin to separate quite late, and then there's this flattening of the curve. And this is the only significant advance in biliary tract cancer in recent years. So, Durva GEM-CIS is now the new standard of care, and undoubtedly, I can tell you that they'll be going on to do an industry-supported phase 3 trial in the adjuvant setting, and that will obviously include perihilar disease. The question of whether it should be used in a neoadjuvant setting is another question, but I hope the next speaker will be talking about this. Let's move on. In terms of post-operative chemoradiation, there is a single study that is often quoted, the SWOG 0809. It's a single-arm phase 2 trial of SBRT in combination with chemotherapy in cholangiocarcinoma with lymph node involvement or R1. And the patients basically went on GEM-CAP and then CAP alone with the SBRT as radiosensitizer. And it actually met its endpoint, but it is a phase 2 trial. There's no comparator, and currently both the major guidelines do not recommend this outside of clinical trials. So in summary, there is a need for a multidisciplinary approach for cholangiocarcinoma, and we absolutely need to make room for it. And I think in general, that would now be accepted. There's no doubt that an oral fluoropyrimidine, either capecitabine or S1 is commonly used in Japan, should absolutely be offered, although it's maybe not possible to say with certainty about the benefit in perihilar disease. The Actica trial has been successful, soon to end recruitment, and it may show that GEM-CIS is a better adjuvant therapy strategy than capecitabine alone, but time will tell. The interpretation of the evidence, to my mind, suggests that in hilar disease, the systemic aspect is possibly more important than the local one. And I think better systemic approaches, which might include immunotherapy, are maybe were indicated. And it would be nice to see a properly designed randomized trial of stereotactic radiotherapy and chemotherapy, but whether that will ever be done, I seriously doubt. So thank you very much, and I'll look forward to the discussion at the end of the session.
So John showed us very nicely that adjuvant therapy could help these patients, but it's also interesting to look into the new adjuvant treatments. I'm called upon Laura Liado from Barcelona. Is she in, or is she by video? She's by video, or is she live?
Hi, good morning. I'm Laura Liado from HBP and Liver Transplantation Unit from Hospital Universitario de Elche in Barcelona, Spain. I'm going to talk about the role of neoadjuvant treatment for hilar cholangiocarcinoma, which and when should be used. It's a pleasure to share this session with all these experts. I'm sure it will be an interesting session. I have no disclosures. Hilar cholangiocarcinoma represents one of the most challenging tumors for HBP surgery. Several classifications have been used, but probably one of the most useful ones is that from Lungas, because it includes its vascular relationship. I'm going to split my presentation in two clear scenarios. The first one is that one for resection. Radical surgery is the only curative option with the goal of radical margin negative tumor resection. Resection is indicated in patients with bismuth 1 to 3, lumens T1 and T2, and tumors T1 to T3. However, survival has not improved during last decades, being inferior to 40% at 5 years. Indeed, even with aggressive surgical approaches, there are high percentages of R1 resections, either radial or longitudinal, and survival decreases in cases of R1 resection or N1 or need of vascular resection, being nearly dismal in all these situations. To improve such results, the question is the role of neoadjuvant therapy. Recent consensus does not include the option of neoadjuvant treatment, neither for resectable patients nor for those patients unresectable as a rescue treatment. However, other consensus, such as this Forum European Society of Medical Oncology, includes the possibility of neoadjuvant treatment in selected cases of patients with a surgical aim. Even it's not specified which are these patients, we can hypothesize that neoadjuvant treatment should be planified in cases which is possible are R1 resection, that is, patients with N1, or the need for vascular resection. However, the literature doesn't elucidate clearly the definition of borderline resectable patients for hilar cholangiocarcinoma. There are few studies which evaluate the utility of neoadjuvant treatment, and indeed, most of them are case studies with a small sample size, and in many cases, they include mixed types of cholangiocarcinoma. Some Japanese groups recently proposed to define borderline resectability as the coexistence of regional lymph node metastases and vascular invasion, and demonstrated that these cases had no better outcome than those patients unresected. Following this concept of either surgical or oncological challenging resectability, this Japanese group underwent this prospective protocol of neoadjuvant chemoradiotherapy for patients with either locally advanced borderline resectable patients or presence of N1. They demonstrated that neoadjuvant treatment is feasible and tolerable, and enabled the downstaging of borderline resectable patients and conversion to surgery in selected locally advanced patients, resulting in an improvement of its prognosis. This large revision of experience of neoadjuvant treatment shows that neoadjuvant therapy is feasible and may increase resectability, but studies are heterogeneous and preclude to establish clear indications. On the other hand, this retrospective study, including only resectable patients, showed no improvement with the use of neoadjuvant treatment. From this other revision, I would like to remark that apart from the heterogeneity of the studies, taking account all of them, only 87 patients were included. Indeed, reports on margin status and pathological report response in the specimen are lacking in many of the studies. Finally, it's difficult to elucidate the best type of treatment because in these studies, the protocols of treatment were different in many of them. And finally, it has to be said that 5-year survival of those patients who underwent surgery after neoadjuvant therapy was only 20% at 5 years. As a conclusion, in the scenario of intent to resect patients, even with low rate of evidence, we can say there is no role for neoadjuvant treatment in resectable patients. There may be some role for borderline and locally advanced patients. There are few evidences on the best therapy, but till now, the most used one is gemcitabine plus cisplatin. Most new phase 3 studies are not planified in this scenario. The only comparative study with different options of chemotherapy was this retrospective one, evaluating the role of FOLFIRINOX. Only 20 patients were included, but it showed improvement in progression-free survival. It may be a way to future studies. Finally, there are several doubts and concerns. The duration of treatment, the risk of increased morbidity during surgical preparation, and the risk of increased postoperative morbidity and mortality. At the end, more prospective phase 2 studies evaluation these issues are needed, especially in the setting of borderline patients, maybe by a Maya protocol similar to those of liver transplantation setting, as we are going to say. The second scenario of my talk is the role of neoadjuvant treatment for patients with indication of liver transplantation for hilar cholangiocarcinoma. The place for aggressive resection or liver transplantation will be addressed afterwards by Dr. Endo. Indication for liver transplantation is clear in patients with bismuth-4 without N1 or distant metastasis. Although size lower than 3 centimeters was established in the Mayo Clinic protocol, recent studies have shown that it may be not so relevant. However, liver transplantation had traditionally bad results in this scenario, and it's also important to face the scarcity of donors. All studies evaluating the usefulness of neoadjuvant treatment in unresectable patients with hilar cholangiocarcinoma have been evaluated in this recent meta-analysis and meta-regression study. It included 20 studies with 428 patients. It is more important to note that there is no randomized control studies, and most of them are non-comparative cohort series. However, the benefit of neoadjuvant treatment is clear because it achieves a decrease of recurrence from 51% to 24% when neoadjuvancy was used, and survival increased from 32 to 65%. However, in this other study, it's pointed out some relevant aspects. Firstly, the difference in prognosis in cases with primary sclerosing cholangitis compared to those patients without primary sclerosing cholangitis. Secondly, and no less important, the high dropout rates. The high dropout rates may reflect that, in fact, neoadjuvant treatment plays a role of selection rather than response. And finally, the high risk of post-liver transplantation morbidity, especially related to vascular complications. Talking about which is the best treatment, in the same meta-analysis describes different treatment as is reflected. As shown, even based on the Mayo Clinic protocol, different schemes are used. Thus, as a conclusion, in the scenario of liver transplantation, I think that there is enough evidence to conclude that neoadjuvant treatment should be indicated always. The type of treatment should be based still now in Mayo Clinic protocol, with capecitabine associated with external radiotherapy and with the use of gemcitabine cisplatin afterwards till transplantation. Once more, there are no studies on photodynamic therapy and immunotherapy in this scenario. And There are also some doubts and concerns, such as the duration of treatment, that probably should be at minimum 3 months to better select the patients, the role of living donor liver transplantation in this setting, and indeed the risk of increased post-transplant morbidity and mortality. During the last 10 years, there has been great improvement and development of systemic therapy for biliary tract cancers. However, most studies are performed for advanced patients, but their results may be useful for future studies in the setting of borderline or unresectable hilar cholangiocarcinoma. Indeed, knowledge of molecular pathways and type of mutation associated with each type of cholangiocarcinoma may allow in the next future the development and study of targeted therapy and immunotherapy. Now, notwithstanding, we need to better understand which agents and which combinations of drugs are most effective and best tolerated. Many thanks for all your attention. I will happy to answer your questions.
Let me call upon for the next talk Dr. Itaro Endo from Japan. He's going to talk to us about transplant or aggressive surgery, which one would finally address all the concerns with hilar cholangiocarcinoma. Dr. Endo.
Hello everyone. First of all, I'd like to express my sincere gratitude to Congress Chairman and local organized committee and the scientific committee for kind invitation to this great meeting. This is my COI disclosure. The treatment of cholangiocarcinoma is challenging because of aggressive nature of the disease, critical location of the tumor in close proximity to vital structures, and the lack of effective adjuvant therapy. Needless to say, accurate diagnosis of tumor extent is the key to accomplish safe and potentially curative resection. However, the ability of completely excise the tumor with negative margin is often limited. Nagoya University has one of the world's largest database of hilar cholangiocarcinoma. This shows that if two favorable conditions, R0 and N0, are achieved with surgical resection, the 5-year survival rate is 67%, which is very good. On the other hand, the 5-year survival rate for cases with positive lymph node or R1 resection is about 20%. One of the drawbacks of surgical resection is the high operative mortality rate. In particular, surgical mortality rates of 10 to 23% have been reported for trisectionectomy. Given that the surgical mortality rate for liver transplantation is 5 to 7%, the mortality rate for trisectionectomy may be even higher. In fact, we used the remnant ICZK value calculated from the future liver remnant volume and ICZK value as a test of hepatic reserve, and the remnant ICZK value below 0.06 is associated with very high operative mortality rate of 17%. To overcome such anatomical and hepatic functional limitations, it was natural to remove the whole liver together with the tumor. However, transplantation of anything and everything was not acceptable from the viewpoint of shortage of donors. The Milan criteria for HCC yielded a 5-year survival rate of 73%. This could be considered a desirable long-term outcome that can be justified. Historical experience with orthotopic liver transplantation for cholangiocarcinoma before 2000 was disappointing, because of the high recurrence rate of the disease. The 5-year survival rate is about 50%, which is almost the same as hepatic resection. Therefore, at that time, in most centers, cholangiocarcinoma has been considered as the contraindication for liver transplantation. However, the Mayo Clinic group has prompted to re-evaluate cholangiocarcinoma as an indication for liver transplantation with the application of strict selection criteria, preoperative irradiation, and chemotherapy, which has resulted in improved survival and has rekindled the debate over the feasibility of orthotopic liver transplantation for selected patients with hilar cholangiocarcinoma. The 30-year results reported by the Mayo Clinic in 2020 are excellent. Survival rate after transplantation are 91, 69, and 62% at 1, 5, and 10 years. In PSC-associated perihilar cholangiocarcinoma, the 5-year survival rate in the per protocol analysis is 76%, which is comparable to HCC within the Milan criteria. On the other hand, de novo carcinoma can achieve a 5-year survival rate of 58% if transplantation can be performed. It should be noted, however, that only 73 of 138 patients, or about half of the patients, proceeded to liver transplantation. We should keep in mind that these are elite cases that have passed through a rigorous patient selection process. This is a US multicenter study published in 2018 comparing liver resection versus liver transplantation. It is important that this study examined de novo non-PSC associated perihilar cholangiocarcinoma in detail. When transplantation was possible, the 5-year survival rate was 54%, but of the 35 patients who entered the protocol with the intention of liver transplantation, only 16 were able to be transplanted. And in the ITT analysis of non-PSC associated cholangiocarcinoma, the two curves are close together up to 40 months. The difference of 5-year survival rate was only 14%. This difference seems to be small as to justify its use for transplantation for non-PSC associated resectable perihilar cholangiocarcinoma in the current shortage of donor livers. Liver transplantation was better than hepatic resection for all 1, 3, and 5-year survival rates, according to a meta-analysis. In the last meta-analysis, the key to the prolonged survival effect is also the absence or presence of neoadjuvant treatment. The upper panel is liver transplantation with NAC-RT, and the 5-year survival rate is about 60%. This is a summary of liver transplantation. PSC-associated perihilar cholangiocarcinoma is a good indication for liver transplantation with a 5-year survival rate of about 75%. On the other hand, the 5-year survival rate of transplantation for non-PSC-associated cholangiocarcinoma is about 60%, which is comparable to the N0 and R0 patients who underwent liver resection. This favorable outcome may be due to the strict patient selection, excluded about half of the rapidly progressing disease. A meta-analysis suggested that NAC-RT is essential for liver transplantation, and the long-term outcomes are better than liver transplantation than with liver resection. However, patient selection is not working in liver resection because most of them are not treated by neoadjuvant chemoradiation. We have recently reviewed the patients before 2008. During this period, there were no adjuvant chemotherapy before and after surgery. Lymph node metastasis and vascular invasion were extracted as the prognostic factors. Patients with both lymph node metastasis and vascular invasion showed no difference with patients with unresectable disease who were treated with multidisciplinary treatment. I think the treatment effect of surgery was questionable in such patients. Therefore, I think that these patients might be considered as borderline resectable in terms of the fact that only dismal outcomes were brought on the surgical resection alone. For these borderline resectable cases, we conducted a clinical study of neoadjuvant chemotherapy using gemcitabine and S1. This was feasible with acceptable side effects, although the results were for the initial 60 cases. We use gemcitabine and S1 regimen. We do 3 cycles before surgical resection. Until the end of 2017, 110 patients received neoadjuvant chemotherapy. About 30% of the cases are rendered unresectable during neoadjuvant chemotherapy, and intraoperative findings such as peritoneal dissemination, distant metastasis, para-aortic node metastasis. Although most of the cases are classified as stable disease by RECIST criteria after neoadjuvant chemotherapy, 2/3 of the patients showed a clinical response when we look at the waterfall plot of CA19-9 level and SUV max by PET scan. This is a result of intention to treat analysis. The overall 5-year survival rate was 33%. This may be reasonable good for patients with suspected vascular invasion and lymph node metastasis. 5-year survival of the resected patients after neoadjuvant chemotherapy is 47%, and the median survival time is 55 months. Zero resection rate was 80%. This is a subgroup analysis concerning lymph node metastasis. The 3-year and 5-year survival rates for NZ patients were 71% and 55% respectively. Comparing liver transplantation with liver resection after neoadjuvant chemotherapy in lymph node negative cases, 3-year and 5-year survival rates are almost equal. Furthermore, positive lymph nodes with poor factor in high-range carcinoma is shown. About 60% of the cases of cancer are positive lymph node metastasis eligible for liver transplantation. The diagnosis of lymph node metastasis is difficult. PIVCA2 have been
Can you check the audio, please?
Recently, other biopsies just DNA missing. If the presence of metastasis can be preemptively increased, the patient transplant may be funded. This
Is it a pre-recorded video or is
carcinoma. If the user is of liberation to me seem the short
anything to do about it? Is it possible to solve it? Sorry?
Section out after
Recorded like that. Okay.
we solve patient. Since without mutation are different, so hepatic action.
Shall we skip it?
The other
Yeah. 30 seconds. Let's stop because I think it won't get better. Thank you.
With another.
Thank you.
Thank you.
So, what should we do? Difficult case. Are any of the attendants? They were online? Is anybody online? Karen? Oh, sorry, Karen. Laura, is she online?
Yeah. Yes. I'm here. Can you hear me?
Good to see you. So.
Nice to see you.
I can imagine that there are a lot of questions. Any questions about the first presentation? Do we still need a new classification, or are we satisfied with that? What's your opinion about that? Any of you? John, you have a strong opinion about this.
I don't have a strong opinion, and I'm not sure I'm going to change anything.
No.
I think classification is quite difficult in that setting, and I think what we would just take a pragmatic approach to what we can see, and I wouldn't be too concerned about classifying anything. What are the big questions? The questions are, can you get the tumour out with a margin? I mean, that's really what it's all
Particularly
about.
preoperatively, and we are also happy when we at all proved pathology-proven tumors, because in 30% of patients we don't have that, so that's still a problem. Yeah. Okay, any questions on this from the floor? Yes, Bas.
Thank you, Geert. Bas Groot-Koerkamp, Rotterdam, Netherlands. I want to applaud all the speakers for amazing presentations. In particular, Karen Brown, I'm not sure you remember, 3 years ago you showed me this case, and where you did primary percutaneous stenting without leaving external drain, without crossing the ampulla. I thought it was brilliant. And you told me you never get the chance to do this, because usually the endoscopists have already ruined it for you. So I took this to the Netherlands, and we've now done this in 20 patients, and the results are really amazing. We do not need re-interventions, we don't see cholangitis, it's really astonishing. And so what I want to tell the audience is that if you want to improve the care for patients with periohyalocholangiocarcinoma, you don't need to do it robotically, you don't need to do arterial reconstructions. Maybe before you introduce adjuvant chemotherapy, please start with primary percutaneous stenting.
Yeah, without passing the papilla.
Exactly, very important.
So you're talking about the functional, thanks Bas, it's good to see you. You're talking about the functional internal external drain. Yes, they seem to work out much better than
No, I'm talking about I'm talking about primary percutaneous stenting.
Well, it depends then if you're talking about resectable patients, right?
So we're doing this now for unresectable patients, and our historical cohort, endoscopically, the 6-month mortality rate is 50%, and these are like top-notch, world-renowned endoscopists. And now we're at 0%. 0% 6-month mortality.
Yeah, but the difference here is not passing the papilla, right?
Not passing the ampulla,
because
but the other thing is not leaving an external drain. So you glue I mean, Dr. Brown can explain it better, but you glue the trajectory, the puncture trajectory. So it's not only that there's no feces going in, but there's also no skin bacteria going in, because it's one thing. And the patient goes home the same day.
It's probably also best to not have the patients even flush the catheters, because that's another way of introducing bacteria, right?
Yes, but we don't even leave catheters.
In the functional ones where you're going to resect them, we don't have them flush. In the patients who are not resectable, yes, primary stent. We just use gel foam in the track because basically I'm very frugal.
But I think actually we need to do this also for the resectable patients. And if you make the comparison with distal obstructions, the surgeons used to be concerned for leaving metal stents.
But
They're
no
not
more.
anymore.
No more.
And I know from Liverpool, for example, they have left endoscopic, but metal stents for a long time. So I think also for resectable, and we're going to explore this in a phase 2 trial, to do primary percutaneous stenting for resectable perihilar as well.
Okay.
You got good results with stenting, but the Japanese have moved away from percutaneous interventions and they try to put a nasobiliary drainage because their take is that if you do any percutaneous intervention, there is seeding of the track and possible recurrence at the PTBD exit site.
Now, are we talking about resectable patients?
Yeah.
So how long are they going to have this nasobiliary too?
Till the resection
Yeah.
is done.
I think that it's pretty well
I'm
been
actually
shown.
quoting Yamamoto and
I think the
Nagoya.
risk of seeding is overemphasized from the past. I can't remember seeing one case of seeding the 30 years I was at Memorial from a pilar cholangia. Maybe one, but it's very rare.
Yeah,
You know,
see
don't forget.
sometimes you see it in the drain, the place where the surgical drain
at
was left.
the exit
Yeah,
site.
exactly.
And that can usually be resected if that was an
Yeah.
issue, or it can be dealt with. I think in the past when we had very big devices and things were much rougher, well, like they were in surgery. I mean, when you think about what happened 30 years ago and 40 years ago when people were reporting this, I think it's
No,
different
I was trying
techniques.
to just bring your attention to the fact that the Japanese moved away from PTBD to nasobiliary because of whatever the reasons is, because they are the ones who actually introduced PTBD in a very aggressive
Yes,
fashion.
they
initially.
certainly
So
did.
That's why I was trying
So
to.
John, how do you do that in Southampton? How do you do it preoperatively?
External.
Yeah.
We do external drainage and recycling, which is
And you were not afraid by the Thomas van Gulik trial that showed the high risk of mortality in the percutaneously treated, preoperatively treated patients?
I mean, we haven't seen it. I mean,
No.
it's not. We haven't seen it as a problem. We are certainly open to new approaches, but currently we
You're
tend
happy
to,
with
we're
what you do.
happy with that. And just to explain how we recycle the bile, they drink it with either Coke or I prefer Guinness, because it covers the taste better and makes the patient
If you
happier.
can stand Guinness, you can also stand
Yeah,
bile.
you can stand bile, yeah.
Can I just say one thing about that mortality rate that was quoted in that paper? So I think, first of all, that mortality rate was out of the realm of conceivability and way above what the SIR standards are in the United States, and something that we don't see. But I think another thing to think about in that paper is don't forget that half the patients transitioned from the endoscopy group to the percutaneous group, and those are the patients that are going to have cholangitis. And cholangitis is one of the biggest issues of mortality at the time of percutaneous biliary drain.
Any questions from the floor?
Will
Sir?
Chapman, St. Louis. Great talks. I think the ideas on how to start in management with IR percutaneous approach first is great in concept and probably will work in many parts of the world. It won't work in Missouri very much because where do the patients come from? Gastroenterologists, and no matter how much we try to prevent that. I'm not saying that we shouldn't quit trying, but they all come, it's already been done. I do think your points of these patients, before they even get percutaneous, before any intervention, they need to be seen by the collective group, including a surgeon, and that's to me, kind of key. I don't think the clinical staging systems are so important because, at least right now, they don't impact management. Are they resectable, transplantable, or not resectable? I think the question, and maybe Dr. Brown, you can answer this, do you think it matters for a patient to have what part of the liver is drained if they're going to have portal vein embolization of that area? And how low does their bilirubin need to be before conducting PVE?
There's no bilirubin level that would keep me from doing a portal vein embo, but I think that, typically if you're doing that, it's in the setting of anticipated resection, and we should be draining the functional liver remnant, which theoretically should have portal vein blood supply. I think the problem with some interventionalists in is that they see big dilated bile ducts and they want to put the catheter in there. It's like oh, I can get in those bile ducts, but that's typically the side of the liver that's atrophic, and that's why the bile ducts are so big, because it's long-standing obstruction. But I think you got to drain the FLR and not worry so much about the bilirubin for the portal vein embo.
So can we move away from this preoperative, because it's so, we can talk about ages for this, and it's, let's move on to chemo, when and where and what. Any questions on that? Any strong opinions on that? I have the feeling that neoadjuvant or induction therapy might be the future, but I didn't hear it that much. That there was not that much evidence, maybe. But John, any comment on that?
Well, there's not much evidence.
What's your feeling?
Well, it works. There's been a trend towards neoadjuvant treatment in a number of cancers, hasn't there? And there's no reason to believe that biliary tract cancer is any different. I think that in pancreas, I see us going towards a neoadjuvant only approach very soon, and I think most places are moving in that direction. Maybe not because, maybe just you're selecting then the patients for surgery that otherwise would recover very quickly. I don't know, but I think that's the trend. There's a particular problem clearly in hilar cholangiocarcinoma of the undrained duct and sepsis, and we've discussed how we can minimize that. I think there needs to be a phase 2 trial just to see how it goes. There's a protocol in the UK that has never quite got going yet. It was one of the casualties of the pandemic. So it's Liverpool based, it's not started yet, but it's a nationally supported trial, so we'd like to see that done, just see if we can make it work. But I think neoadjuvant is a way forward. The question is what are you going to use? I mean, if you believe that, the Topaz trial is very convincing, so I think if you're going to do anything, you go with the maximalist approach, which would be Durval plus gemcis.
Yep.
No, yep. I can't see why you'd use anything else.
Maybe the Actica will show you somewhere.
Well, maybe Actica will show that it's better as adjuvant, but in the neoadjuvant setting, I mean, I think you've got to go with the best regimen, which would be immuno plus gemcis.
Any comments on that, Laura, from the Barcelona idea?
Yes, thanks. Do you hear me?
Yes,
correctly?
Very well.
Yes? Well, okay, thanks. I agree with Professor Wilmore. I think the ongoing studies in unresectable patients with immunotherapy may be the way afterwards to implement them in the neoadjuvant stage. I think we have to wait for the results in palliative treatments and to see if this works with immunotherapy, like Durvalumab or some of them. Some studies, like the Professor Endo has presented from the Japanese group, for patients with N1 or risk of R1 patients, as we have seen in the pancreatic resection. No, we think we will move in this direction in next years.
So do you think there's also room? Does anybody has any results with induction? So that means a formerly not resectable patient becomes resectable after induction chemo or immunochemotherapy. Have you ever seen that? Because we start doing it more and more, and we promise patients maybe you become resectable. But I must say that I have not very positive.
We recently had a young woman with PSC and who developed a cholangiocarcinoma, and there was concern over the portal vein. And in fact, we're not a transplant centre, so I actually sent her to Birmingham, which is the nearest transplant centre to us, and with the view to portal vein resection and grafting, because they have it on the shelf. In fact, on gemcis, she responded enough that she didn't actually need a portal vein resection. So any case series, n equals 1.
Yeah.
I'm not sure you can make much of that.
No, but it's really, really rare that you achieve something extra with this induction.
But this was, it's a 30-year-old, so you really want to try and do the best. And I think think that was successful, but I'm not aware of any convincing data.
Anybody from the audience that has any questions left? Some strong opinions about transplantation? A small word on transplantation, John? Are you a believer? What would you do if you had, there's a liver for you, waiting, you develop a liver?
What, me?
Yeah, you.
Me personally, have I had it? Yeah, I have it. Yeah, I'll have the liver.
I put it in.
But I think I think the issue, and in the UK we are starting a program, and Chris might want to
Oh, sure, I didn't
talk about it because he's more experienced than me.
Sorry, Will was ahead of me, so.
Well, my comment is brief. I think our surgical results are so terrible, even when we think things are optimized, that I think there's a interest and shift towards transplantation. And there are a number of reports, they're highly selected patients, they've got to be node negative, but in those patients, it's about a 50% long-term survival, and we don't achieve that with resection. So I think there's a shift even towards transplant for technically resectable patients. At least that's the interest that I think we're
The
seeing.
interesting thing is also that the outcomes, 5-year survival outcomes, are even better than HCC in some cases.
Yes.
Still, we have difficulties and introducing this technique because we say it takes livers away. But we put them in HCC patients as well.
We have a lot of livers that are unutilized in this country and in Europe also. A lot. There's room to expand, I think.
I would second that. So I think it's the colorectal argument that we had a couple of days ago where people said for liver transplantation for colorectal mets, again, it's equivalent to HCC or better than HCC. I think in the UK, we have come up with a protocol which is slightly modified from the Mayo protocol, and we're going to use proton beam as well, and then follow it up with transplants. So the protocol will be rolled out by autumn this year. So the feasibility is done, the implementation is now just started. So you will probably see it in publication by summer, and it'll be rolled out by autumn this year. But it's on the cards, and I think liver transplantation for cholangiocarcinoma, particularly intrahepatic cholangiocarcinoma, is very straightforward, I think. Thank you.
Thanks. Any further queries and comments? If not, I think we'll be closing the symposium now. I thank my co-chair, Dr. Gee, the speakers, Karen Brown, Dr. Primrose, and Dr. Laura. So thank you all.
Thank you. Nice meeting you.
So you from Germany?
No, from Holland. They put it in. Yeah, I'm from Mexico.
Just check with Christina. End of the day. I did just check with Christina that this was accurate. If you want to use that, I don't know if you care to use
I
that
have.
stuff. I think you can come up. There's so much room.
Yeah, we can have them up here from the very beginning.
Yeah, I think so. Just to introduce you to her, just check with them.
512. Okay, good afternoon. We will end the day and actually the Congress with a debate. Local regional therapy for margin sterilization following in pancreatic cancer, and we have two options that the presenters will argue for: either IORT, intraoperative radiotherapy, or the use of irreversible electroporation. We'll give them 15 minutes each, and then there will be a debate. I hope you will still have energy for some questions, and there will absolutely be energy in between the presenters. I'm sure of that. My name is Roland Andersson. I come from Lund in Sweden, and I'm sharing this session together with Kim Burtons from Toronto, right?
Ottawa.
Okay.
Ottawa.
Close. Okay, first out. I advocate for intraoperative radiotherapy. You should always check up people that talk if it's others' work or their own. You have actually published on the particular issue. That's a merit. Okay, please.
Well, thank you very much for giving me the opportunity to debate today, and I'm surprised that anyone is actually in the audience, because we kind of thought it would just be the four of us, and we figured we might as well go for a coffee instead. But we're happy that you're here, and we hope that you'll ask some questions and give us a hard time, so this really becomes a debate rather than just the two of us talking to each other. So I do have some disclosures, as you can see above, for research and some honorary fees. So this is really this whole question about locally advanced disease, right? When can we not get an R0 resection? Because metastatic disease is a whole different ballgame. And this is really about that middle group of borderline and locally advanced disease. And you know, we know that what probably has had the biggest impact on the survival of pancreatic cancer patients is systemic therapy. I put the ACCORD trial up here, but obviously gem-nab-paclitaxel also has incredible results. But it really was just to emphasize that this is survivals. We do really need to treat the systemic disease, and that's why chemotherapy is always part of our multimodality approach. So what is the role of IORT? So I'm going to show some of these slides and then try to contrast with some of the IRE technology that's out there. So IORT has been around for a long time. So we have history on our side. I'm very fortunate. Dr. Warshaw, who was my chairman, had started the program with Chris Willett back in the 70s. So my institution loves IORT. But we also have a very long history with it and a lot of experience with it. Now, this, again, is not the newest machine, but one of the downsides of IORT is that it does require a machine, and the machine costs about $1 million. So that's a lot of money, right? And if you're only going to use it for pancreas, I don't think that your administrative team will probably sign off on that unless you think you're going to use it 200 to 300 times a year. So that is a downside. But the good thing is that they also have indications for other tumor types, especially breast, and our colorectal surgeons use it as well. But again, it requires an OR, and you 1970s, and it's actually OR 43, which has all these metal shields in it. so everyone is protected and the machine fits in very well. But as you think about starting a new program, those are all things that you need to consider, and that's obviously different than IRE, where it's a small mobile machine, and when we do IRE, we share it with our interventional radiologists, so that's nice that you can do some sharing with other departments. Now, when we do IRT as surgeons, we do not get paid. The radiation oncologist gets paid. So you're sharing with another department, but in a very different way. Whereas when I do IRE in the OR, and I don't do it for pancreas anymore, but I do it for liver, I, the surgeon, and the Department of Surgery gets reimbursed. There, though, you're talking about a machine that has an initial cost, and then each needle that you use costs a significant amount of money, and depending on how many you use. And I don't remember the exact quote of what each probe costs, but it's about, what I recollect is about $1,000, but I'm sure you'll touch on that. I'm sure in the US it costs 10 times more than it does anyplace else in the world. But here, it's nice because with IORT, you can, with the radiation oncologist, put the cone over the resected field. A certain distance apart so that you can be effective. And sometimes placing those needles, at least when I did some pancreas cases, I thought was a lot more difficult than putting the cone right over my area that I wanted to treat. And so I think for both modalities, you have direct visualization, right? And one has to be ultrasound guidance, one is putting it straight onto the tumor. So I think technically probably a little bit easier. For both of them, you can shield normal tissue, and you know the electron they can adjust the depth of radiation. But with IRE, you can also adjust the tumor that you're treating. But if we do unresectable patients, we can still radiate them. Whereas if the patient has a metal stent in place, IRE can't be done because it can't be done with the metal stent in the head of the pancreas. The operator of the machine to show up, whereas for IORT, you need a fairly large group of people to help you. Now, the surgeon, the anesthesiologist, the pathologist, and the nurses, that's all the same, but now you need the radiation oncologist, you need the physicists and the therapists and the engineers. And so when we do IORT, there's sort of like a swarm of about 6 people that come quickly into the OR. We get everything set up and we do the IORT. But that is, you know, extra personnel that does have to be accounted as an advantage, and again, it's because it's been around a lot longer. And we know that even in the setting of neoadjuvant therapy, we think that there is a helpful benefit to local control. For margins, you know, IRE can be used for margin accentuation as well as IORT for margin accentuation. We have this data from MGH, but there's obviously a lot of IRE data in the literature. The doses of radiation obviously vary whether you're going to resect the patient or not resect the patient. And here you can see that we have about 13% of patients who recur locally. So it's great, but not perfect. And even for the patients who have the tumor in place, we still have good tumor control, and only 15% of them had local progression. You know, unfortunately, many of these patients continue to have distant metastases. Complication rate and the mortality data. Now, this is our data from MGH, okay? So again, it's only single institution, and we are way beyond our learning curve, right? If you started in the 70s, if we haven't hit the plateau yet in 2022, then we're really in big trouble. But so I take that into consideration, and with IRE, there's definitely much more of a learning curve, and the complication rate in anything that we do is higher the earlier that we are in the process. But you can see for the patients who had a Whipple and IORT, there was no mortality, and about 12% had a Clavien grade 3-4 complication. And that's very similar to those patients who do not get IORT and just get a Whipple. For the distal pancreatectomies in IORT, again, the grade 3, 4 complications are about 15%, and there was no mortality. So those numbers are very similar to those patients who we take care of who get the operation but do not get intraoperative radiation therapy. So what about the people who get no resection but get intraoperative radiation therapy? You can see that there's still a 5% Clavien grade 3, 4 complication. There was one mortality within 9. But we still have to include it in this group because it was within the 90 days of the operation. But to keep that in mind, the IRE data, which I know will be presented later, the significant morbidity and mortality from that is significantly higher than what we see with intraoperative radiation therapy, at least in the meta-analyses that have been done where they've put multiple groups together. So very quickly, a plug for the PACER trial in case any of you have intraoperative radiation therapy machines. This is going to be really a nice trial that will give us data from outside of the MGH, because the criticism is always, well, that's nice, I'm glad you guys do that at the MGH, but what about, is it scalable? Will other people have the same types of results? So for patients who have borderline and locally advanced disease, they get chemotherapy, they get external beam radiation, and then they can be registered to get an exploration with IORT, looking at the 2-year overall survival endpoint as the primary endpoint, but also local control, progression-free survival, and the morbidity and mortality that is associated with adding the radiation. And I think that that's going to be really helpful in terms of comparing it to other modalities. Just very quickly, patient eligibility, exclusion criteria, treatment setup. And again, you have to do this within 12 weeks of completing your external beam radiation. And as I mentioned before, placing the cone, and you do it with the radiation oncologist. So it's actually a nice collaborative effort, but the surgeons don't get paid for it. So here are their numbers. 64 patients have already been enrolled across many institutions, but I spoke to several people who have this technology but are using it for other tumors that hopefully will join us in the PACER trial. So I think in summary, IRT provides another modality for local control. I think in comparison to IRE, I think it's easier to use. You do it in conjunction with another service, which adds for a nice collaboration. The morbidity and mortality from adding the radiation is negligible. And I think that in patients who don't have long to live, making sure that you don't add to their morbidity and take away from their quality of life as you try to control their local disease is really important to consider. But the downside is it does require more infrastructure in terms of the room, in terms of the machine, and the initial cost of the machine is quite expensive. Once you have the machine and the cones, all you have to do is sterilize the cones. So it's the cost of sterilization, but it's not that you have to throw away a lot of things. But again, multidisciplinary care is going to be the key to everything that we do for this disease. So, and thank you to my group who I get so lucky to work with. Thank you.
Thank you.
For IRE.
Thank you, Kim. Good afternoon. As Christine already pointed out, we got more than what we thought in the room, so it's a great start. I think the way I'm going to go about this is clearly when you're talking about two technologies that are one that's been there for some time and one that's relatively new, there is going to be paucity of data. So that's our starting point, and I'll show you why. So those are my disclosures. So if you look at IORT versus IRE, there is paucity, 54, for IRE and margins, and there is real paucity, okay? That's 4 results, okay? So I could stop the debate here and move on, but Christina's a really nice person, and I thought I'll take on this argument a bit more systematically and kill it, but kill it in a really nice way. So what I'm going to do is I'm going to talk to you about the definition of margin sterilization, share with you some of the technology, because as Christina pointed out, this is relatively new kid on the block, and talk about what are the risk margins in pancreas particularly and liver, and the technique and evidence for margin sterilization in liver and pancreas. And what is the evidence? Christina's already alluded to some of it from IORT and MS, but I'm going to try and take a look at it in a slightly different way. And then we're going to try and summarize some of this evidence of IRE versus IORT and let you decide where you want to be. So what do we understand by margin sterilization? So for me, it's equivalent to margin accentuation. That's what we call, and that's what Rob Martin devised as before when he started off doing this. It's basically death of the cancer cells at the margin. But the most important bit is, it is prior to resection. Because once you take the resection specimen out, that is irradiation or IRA to the bed. That's not a margin. The margin doesn't exist anymore. And the second thing is, are you able to actually demonstrate cell death? Because it's all right to blast it with a bit of IORT, please don't take it wrongly, but are you actually able to show what's happening to the cells at a cellular level? So if you talk about IRE, this is what IRE is about. Sorry, this is going to play a little bit before we get to the bit which is irreversible. So there we go. So that's the irreversible bit of the electroporation, which is what we're interested in. Because if you do get into that range, which is about 2,000, over 1,500 kilovolts, then what you see is cell death. So you get permanent nanopores, and you get what we call the extrusion of the cell contents and cell death by apoptosis. Now that's the way IRE works. So what is the at-risk margin in pancreatic ductal adenocarcinoma? Because we all know that a positive margin, and I'm sure you won't disagree, equates to poor survival. Now, I'm going to share with you some of the work that we did way back in 2000, where we looked at the margins in Leeds, where I used to work before, in a more rigorous manner. And what we did was we combined axial slicing of the specimens and combined that with inking of the margins. And when you look at it in a more detailed and a rigorous manner, what we showed, and this was published in the British Journal of Surgery, was that 85% of the resections, resectable cancers, or what we call resectable cancers, were R1 on the standardized protocol. However, we were in some ways heavily criticized because it was so that this is as a result of poor surgery. So we went specimens, you could say that the true R0 resections had a better outcome. However, it took Marcus Buechler to validate this in a larger cohort and say that most pancreatic cancer resections are R1 resections, and then the world started to take notice. So why am I going around this? Because we need to define what are the risk margins. So the risk margins are posterior margin, the SMV margin, and the SMA margin, to a lesser extent than neck. So the question I pose, or we posed as a unit, is in resectable cancer, could IRE to the margins reduce margin positivity? In other words, sterilize the margins or accentuate the margins. So we're going to focus on, unlike what Christina said about locally advanced cancer or borderline resectable, on the role of IRE in margin accentuation for resectable cancer, because as I've shown you, in resectable cancer, you still have a high R1 rate. So the surgical strategy was that with minimal mobilization of the pancreas prior to the Whipples, you do an intraoperative ultrasound, you do irreversible electroporation to the margins that I've described, to the SMV, posterior, and pancreatic neck. You can see deliberately excluded is the SMA, because when we were starting off, we knew this is going to be a learning curve, and she's absolutely right about that, that there is a learning curve to the technology, and we did not want to run into major complications. Right? And you can see the pictorial demonstration. You can get a zone of electroporation around the area where you're going to do the margin accentuation. And you do the posterior margin, you do the neck margin first, then you do the SMV margin where the needles go parallel to the SMV groove, and you sterilize that margin, and then you move to the posterior margin. Now this can be quite tricky because you place the needles, probe 1 and probe 2, do the first zone, and then you have to move probe 1 transduodenally across into the upper position to complete the whole posterior margin. So it's a fairly detailed killing of the margins in a systematic manner based on the knowledge of our margins from the previous studies. So what happens when you look at this in a macro? that's what you see. So you actually get necrosis of the cells, and you confirm that on micro. Now, it's necrosis because the specimen's been taken out, so there's no blood supply. Otherwise, in real time, you'd see apoptosis, so that's the difference. So we published the technique, and we thought, this isn't good enough. We've got to now show, is this going to be feasible? So we moved on to do our first trial, which is the margin accentuation study, the MACPI-1, which was to look at whether or not we could do this in patients to reduce margin positivity. So the percentage reduction in margin positivity in the IRE group compared to the non-IRE group was a primary outcome. There were several secondary outcomes, and most importantly, from our point of view, was complications, because we wanted to make sure when you're using novel technology, you did not want to run into too many complications. This was a sample size, 20 versus 91 that we needed. And as you can see from the demographics, not much of a difference between the IRE and the non-IRE group. But if you focus on, and again, if you look at the type of operation, there were more standard pancreatic adenoidectomies in the IRE group versus the non-IRE. Most importantly, there was no difference in the complications rate between the IRE and the non-IRE group. If you focus on the area which is most important, which is the margins, as you can see there was no significant difference in the margin positivity overall between the two groups. However, if you started to tease it down into the specific margins, there was a trend towards a statistic more. We did not do the SMA margin, but if we had done the SMA margin, there would have been a statistical significant difference between the IRE and the non-IRE group for margin accentuation. So deliberately, obviously this is an extrapolation from the results that we've drawn. I wouldn't talk too much to the survival because it's a pilot study, so you can't really see a difference, but again, don't read too much into it, and I'm not going to draw too many conclusions from that. So the study summary essentially showed IRE has been safe and efficacious. There is a significant reduction in the posterior margin positivity, and margin accentuation may have a potential role to improve survival or outcomes in resectable pancreatic cancer. Having done that, we've now moved on to the next stage, and as Christina said, one of the important things is you can do it in your center. Can you do it in more centers? Now, demonstrate in other centers, but with this particular technique, can we replicate it in other centers? So the multi-center MACPI-2 study is going to involve Manchester University Hospital and Royal Free, and it's a feasibility study looking at the efficacy and safety of IRE in multiple centers and recruitment. We're also going to run two trials. One is NeoPanc, because in the UK it's slightly different. You want to take on a trial, you got to show in stages. So we wanted to combine neoadjuvant therapy with IRE, but they wouldn't allow us to do that. So we got to first demonstrate neoadjuvant therapy in pancreatic cancer and then do neo-MACPI. So those are the other two trials that are coming up. So this was a systematic review that was published from Newcastle, which is looking at margin accentuation in patients with stage 3 cancer. And as you can see, this particular study, again, includes papers from Rob Martin and his group, and concluded basically that this is early non-randomized evidence to suggest that margin accentuation can improve R0 resection. What about IRE and margin sterilization in liver tumors? Because this is something that I thought that it's not been specified as pancreas, so I just wanted to share something with you in liver. So again, from liver tumors, we know that the IRE has an advantage that does not damage Peter Kingham, he published this study where they looked at recurrence patterns following IRE for hepatic malignancies. And they did the IRE to tumors that were close to the vascular structures and concluded that actually there is a potential and a significant rate of reduction in recurrence in patients who were treated with IRE. So the second study, which is interesting, came from the Netherlands, which is CoalFire-1, which looked at ablate the tumor where the margin is at risk and then resect it and see whether or not you get a vitality. And they actually showed you get a vitality in the tumors. So based on this theory, if you look at tumors which are in the liver, and if you've got a tumor which is located in the area of the nestling between the right and the middle veins, as you can see here, you can do IRE to that tumor, sorry, going back, you can do IRE to that tumor, which is at risk margin, and complete your right hepatectomy. Similarly, if you got to do a tumor which is located close to the right hepatic vein, and you got multiple other tumors in a parenchymal sparing fashion, you can do IRE to the tumor, resect it, and proceed to do non-anatomical resections of the remaining tumors. So this is a concept. This is a concept that we're going to try and take forward, and particularly with laparoscopic 3D liver surgery, whether we can do the ablate and resect with IRE. Now, this is where we do it, and as you can see here, we can achieve this avitality. As you can see, the zone of electroporation, which has killed the cells around the margin, which was at risk close to the inferior vena cava for a segment 1 resection. So ultimately, I would say as far as liver is concerned, I put my hands up, IRE and margin sterilization. There's no data, but there's a potential application. So we park it there. So we come to the important bit, which is IORT and margin sterilization. And we've talked about this study, and I'm going to highlight a few important points. Neoadjuvant FOLFIRINOX and chemoradiation. Okay, so that's the first two bits. IORT comes after that. So that's not mentioned. So this is, where is the benefit? Is it neoadjuvant that's giving you the benefit? Or is it external beam radiation? Or is it really IORT that's giving you the benefit? I don't know. So if you look at the data, again, Christina's talked to this a little bit, but I'm going to look at it slightly differently. So if you look at the borderline resectable group, there was significantly more in the non-IORT group compared to the IORT. So in other words, there were different, there was probably some kind of a selection bias without going into the details. If you look at the R0 and R1 rates, again, no difference. So you didn't achieve anything by doing IORT. If you look at the survival curves, and Christina talked to this, it's good to see the difference when you look at the R0 group versus the R1, and that's clear. But when you look at the R1 group a bit more in detail, the numbers at risk are very, very small. So therefore, interpretation of these results have to be with caution. And they have used caution because they've said that IORT may be able to invoke cell death by sterilizing margins, mitigating the effects of an R1 resection. Great thought, but at best is a hypothesis. So what about the second paper? I picked 2 out of the 4. So this is the second one, which is again looking again at neoadjuvant treatment. So you've got patients who've been treated with neoadjuvant therapy and then have had IORT. So I would say this is IORT done post-resection. So you've already cleared the bed, and then you're going to give IORT. So where is the margin? There is no margin. So again, you can look at the numbers here, 32 patients who underwent FOLFIRINOX therapy. And again, if you look at the group of patients who had the neoadjuvant therapy, this is combination of Whipples, distal pancreatectomies, apples and oranges all put together to try and get a possibly higher R0 rate, which is great. But what is the reason you got the R0 rate? Is it neoadjuvant? Is it external beam? Or is it IORT? So the survival rates look very impressive, but I take you back to the graph. Numbers at risk, 1 patient. 1 patient. I mean, that isn't really a true survival advantage. So, sorry, Christina. If you look at the details in terms of the recurrence, and again, Christina spoke to this, most of the recurrence occurs systemically, so which is why you actually see the long-term benefits are lost. And again, IORT combined with surgical resection appears to be associated with improved survival. However, I would add to that, neoadjuvant therapy plus IORT post-resection perhaps gives you that advantage. This is a trial. I don't know whether this is, I couldn't find details about it, but this is exciting. Now, if this comes out, it actually shows in isolation that IORT would be perhaps beneficial in resectable pancreas cancer. And I would be really interested in this trial when the results come out. So if you talk about IORT in pancreatic cancer, borderline resectable and locally advanced, I think are clubbed together, which perhaps is not the right way to go about it. And the PACER trial probably is a better trial and answer some of those questions that we're talking to. IORT in the tumor bed, I can't see any demonstration of cell death, so I don't know what happens in terms of margin sterilization. Once resection's done and the margin's been transgressed, it's not a bed anymore and it's not a margin anymore. So there is no versatility. So it's limited to PDAC. And I will give this to Christina that they've already said that they have not demonstrated feasibility outside MGH, but hopefully that's going to come through. Is this a neoadjuvant effect? Who knows? So IRE and margin sterilization, there's a clear demonstration of cell death at the margins. There's a true benefit and not synergistic with other treatment. The evidence is accruing slowly in the pancreas, and I'm not saying we're there yet, but we're getting there with MACPI-1 and MACPI-2. MACPI-2 has actually reached the stage 2 of the funding. Our process is a bit complex for NIHR, so we're waiting to hear whether we get the money for it, and then there'll be neo-MACPI to follow. From the liver, I think there's a lot of evidence still to be collected, so I wouldn't really push for liver at this moment, although coal-fire 1 and 2 will be hopefully evidence that'll come in light soon. So, head-to-head, demonstration of margin sterilization with IRE, yes. MS, who knows, with the IORT. True IRE effect, yes. Is it a true IORT effect? I don't think so. Is it applicable for the liver and the pancreas? For IRE, yes. For IORT, at the moment, for pancreas alone. Multi-center feasibility, I think IRE has already demonstrated it across the Atlantic, but for IORT, it's still ongoing. In terms of systematic accrual of evidence, I think it's happening. I agree, I'd give this actually a green tick, because from the PACER trial, I think there'll be more evidence coming out with IORT. So I've got nothing against IORT, but I think in terms of the argument and the case today, there's insufficient evidence. The safety and efficacy of both of them are pretty good. So I would say, in conclusion, IORT and margin sterilization, as my New Yorker tennis hero would say, you cannot be serious. Thank you.
I'm very happy that Chris stepped it up a notch, because then I can step it up a notch too without feeling like I'm the mean Harvard person. So I will give you liver, but if we're going to talk about other tumors, then we can talk about the sarcomas that we do, the rectal cancer we do. So let's leave this at pancreas. Let's ignore the liver data, and I won't talk about colorectal and sarcoma. So you look at the margins on your microscope, but none of that means anything if you're not showing me the data of local control. What is the long-term local control? And IRE's local control rates in the meta-analyses are not as low as 12%, right? And we know that we can radiate the entire bed, right? It is a 4 to 5 centimeter cone that's going into the area. So I'm sterilizing the SMA, the SMV, I'm sterilizing the retroperitoneal margin, and in the end, local control is the only true way to measure that your margins are negative, right? Because that's the long term. Then I would also say is, yes, I focused on borderline and locally advanced, and all those patients got neoadjuvant therapy. I can actually confidently stand up here and say that if anybody is taking borderline and locally advanced patients to the operating room without neoadjuvant therapy, they're making a mistake, because they're going to hurt somebody and not help them, right? So when you're talking about upfront resectable disease, I think that that's still a big debate, right? And this is why we're running the Alliance 21806 trial, looking at neoadjuvant versus adjuvant FOLFIRINOX in patients who have resectable disease. So we'll get to that, right? But when we're talking about local control, I need you to show me those numbers for local control. And the meta-analysis that you brought up, you could have skimmed over, but the mortality from the IRE, when putting all the studies together, was 6% from the IRE. These were people who weren't resected. And if we're talking about borderline locally advanced patients, you're going to put them through another ERCP, because you got to take that covered metal stent out. And the covered metal stent in America costs a lot of money. And the ERCP costs a lot of money. And the patient's having another procedure, so that you can put plastic stents in so that you can do your IRE. So what I would say is, I think that obviously you can consider both modalities, but the user experience, that learning curve is going to be much, much more significant using IRE. The expense of using it each time is significant, because each probe is disposable. And it costs about $1,000 per probe, and so you need a minimum of 2, is $2,000, and then if you start to use more probes to try to make it go faster, you're increasing the price. We really want to know what in the end, local control is, and we have some nice long-term data and can tell you that only 12% of patients progressed locally if they were resected. And even the ones who were not resected, so the whole tumor is in place, only 15% had local progression. So it's hard to imagine that the IORT, even though we're not seeing it under the microscope, the true effect in the patient we have as a surrogate and probably more valuable marker than the microscope. So thank you.
Thank you, Christina. So I think take this one by one because there's quite a lot in there. So the first bit is about the fact that it's perhaps a difficult technology to master, and I agree with that. Having said that, it's a much more precise technology because as you've seen there, and you don't need more than 2 needles because you use the same 2 needles for each of those margins. You don't have to use 6 because this is not treating IRE for a palliative locally advanced pancreatic cancer. So you just need 2 needles for all the margins that you're going to use. I think it's a much more precise, and I just showed you, the difficulty is if you're going to approach this in an evidence-based systematic fashion, you have to show, first of all, that it's actually feasible in a pilot study, which is what we have shown. To scale it up, we wanted to go down the neo-MACPI route, and as I mentioned to you in the talk, that we in the UK are not allowed to use neoadjuvant chemotherapy upfront unless it's as a part of a trial. So again, we have to show first in a feasibility fashion whether we can do neoadjuvant chemotherapy in resectable patients, and then move on to the neo-MACPI, which will be the combining of the neoadjuvant with the IRE. Because I completely agree with Christina that in terms of borderline resectable, no patient, I think, should ever go on to surgery up front. They should have chemotherapy prior to having surgery. That is standard. Until now, we had several trials going on, so we used to accrue them onto the trial. But the trials have all finished now, so I think we're waiting for the results to come through. So I think from borderline resectable, I don't have any arguments. That's very straightforward. I think in terms of where we go from here in terms of IRE versus IORT, I think IORT, my concern is that, I think it's first to understand IRE the way we've seen it, and the way I've done it in terms of our understanding of margins is very different from North America. So I think the North American understanding of margins and our understanding and take on margins is different. And that's not to say it's inferior, it's just different. So I think we treat the margins in a different way because we like to place the needles. When we didn't do the SMA, it was only for the learning curve bit. I think now that we've got better with the technology, I think we can do the SMA in a precise manner, as I showed you the SMV groove in that picture. So I think you can achieve precision because we do it always with our radiologists in theater, and it's not very difficult to position the needles and make sure you get good electroporation. So I think from a technology point of view, it's there. Obviously, IORT has been there for a longer time. IRE has only been there for the best part of, I think certainly we've been using it since 2014. So it's probably about 7, 8 years. So it's not a long time that we've been using it. So there is a learning curve to it, but you get better with it as you do it. I think in terms of the cost, I'm not so sure. So we've managed to get, so none of the studies that I've done are commercially funded. And the reason I didn't do it commercially funded is because you want to keep the meritocracy of the study because you don't want to fund it commercially and then get the conclusion that people interpret in a different way. So none of our studies are commercially funded. But what we have done is we got a business case put together for IRE for liver, for pancreas, and locally advanced pancreas. So the trust, and as we call it in the UK, funds the machine and funds the needles because we use it quite extensively for our liver tumors as well. So I think in a business case fashion, it's worked out well for us. And if you do get the money for the trial, that will fund the needles for the second bit of the study. Overall, where do we sit in terms of both the technologies? I do think IORT has a role to play, but I just haven't seen it in isolation work. So show me IORT in isolation, working, and then I will believe it. In resectable cancer. And the reason I say resectable cancer is because in resectable cancer, if you look hard enough, your margin positivity rates are much higher than you think. And the survival data supports that. If you had R0 rate, which was 70% in resectable cancer, why is it then you're seeing a 20% 5-year survival? You shouldn't be seeing that. You should be seeing much better survival. But the reason you don't is because you're not looked hard enough for the margin positivity. But if you look for it hard enough, you will find it. And it's been demonstrated, across Europe now, the same protocol is used in terms of analyzing margins, including at Heidelberg. So I think overall, I do think IRE has a role to play, and IRT probably will have a role to play, but I want to see it work in isolation. I'm not there with IRE yet, but I'm just trying to approach it in a systematic manner, and I'm not going to stand up here and say that we have all the evidence to say IRE is the best treatment. I don't think this debate is about that. I think this debate is about two technologies in a slightly nuanced fashion being used in pancreatic cancer, and it's a question of which bit is going to work better for the future, and I think only randomized trials are going to give us that answer. Thank you.
Thank you. Question from the floor. Yeah, please.
Thanks to both of you, Christina and Krish. I enjoyed the talks. I think it may be difficult to prove the value of IRT in isolation, and certainly in borderline resectable pancreatic cancer, where I would agree with Christina, no one would consider treat patients with borderline resectable without previous neoadjuvant chemo or even sequential chemo and chemoradiation. The paradox, Chris, is that you find that patients who have been treated with the neoadjuvant treatment have a lower risk of having a positive margin than patients with resectable disease who are exploring surgery resected up front. So that is a paradox, and it's a paradox which forms the basis of what I'm pretty sure and I believe is going to be the future, where in 10 years from now, with the HPBA 2032, we'll probably discuss the results of some trial on the value of neoadjuvant in resectable pancreatic cancer, which will become the standard. My question to you is, considering, and just specifically a patient with borderline resectable disease, for what we just said right now, how can you say that it is a necessary margin sterilization? How can you be sure that you are sterilizing margins which could have already been sterilized by the neoadjuvant treatment beforehand?
Okay, so this is for borderline resectable.
Yes.
Yeah, so for borderline resectable at the moment, we are not doing IRE for those in a trial fashion.
Right, so you treat only patients with resectable disease.
Borderline resectable tumors in our unit, all of them will get neoadjuvant chemotherapy. Either as a part of a trial or outside the trial, they will get FOLFIRINOX. None of them will go for surgery up front. So after a period of chemotherapy, which is usually 4 cycles, what we do is we restage them, and if they've not progressed, and if they're resectable, we'd go ahead and resect them. So a period of systemic chemotherapy before proceeding to resection. We don't do IRE in those as part of the study. So these are all resectable patients that we talked about in that group, MACPI-1. So it's not borderline resectable, they're all resectable. Question about neoadjuvant therapy in resectables is a fantastic question, and as Mike DeAngelica was speaking, and I was talking to him earlier, this is something that we've been talking about should have happened 15 years ago, okay? Because it was a no-brainer that pancreatic cancer is a systemic disease at the outset. We all believe that, all the people sitting in this room will believe that. So I think the NeoPanc, which we are going to start, which is a feasibility study for neoadjuvant therapy in resectable cancer, will answer first part of that question. But for me, the 4-arm NeoMACPI study, which is going to use neoadjuvant chemotherapy, short course, very much like the Foxtrot for colorectal cancer, which is what, didn't have any evidence base to it, but still became acceptable now. So you give short course neoadjuvant chemotherapy, you then do the resection and give adjuvant chemotherapy, that's arm 1. Arm 2 is actually do standard surgery followed by adjuvant chemotherapy. Arm 3 is going to be surgery, IRE, followed by adjuvant chemotherapy. And arm 4 is a full shebang, IRE, neoadjuvant chemotherapy, surgery plus IRE, followed by adjuvant chemotherapy. So that's the 4-arm trial that I could not push through because NIHR would not support that. And PAG would not support that. The Pancreatic Cancer UK wouldn't support that. And I can understand that because, there's you're putting in too many things in there in terms of variables. So, but it's a great point that, I think in resectable cancer in 10, 20 years' time.
As you know,
absolutely.
As you know, the NeoPAC, if I remember well, in Zurich had failed to recruit specifically because there was difficulty in recruiting patients with the resectable disease, and selling these to patients sometimes is difficult.
Yeah.
Although everybody probably accept the failure to respond to treatment is probably a failure to respond to surgery anyway.
Correct.
So it's not a battle we win only with surgery, and I think all the surgeons in this society would accept that.
Yeah, no, I think completely agree. Christina, do you want to?
Yeah, no, I completely agree with, and it's, it's a little bit of a different situation if you're talking about upfront resectable versus borderline versus locally advanced when we're talking about all these margins. And I agree with you. I think our margin positivity rate is higher than we document based on the pathologic assessment.
Have you used the IORT in the resectable patients at all, or?
So because it requires a special room, you may have to make sure that this is a person where you think that you're suspicious that you might end up with a positive margin. And so if they're clearly resectable, they tend not to be in that room. And this is a downside of, with IRE, you can just wheel the machine in as long as nobody else is using it and use it as long as you put the pads on the patient and then do that. Except the problem is that sometimes you don't know you will have a positive margin, and you can't do IRE after you've resected it, right? IORT, we preferentially do once the specimen is out so that we can truly radiate the area that we think is of highest risk. And the cone placement is super easy. It's literally like you say, okay, here's where I'm suspicious. You take the cone, you look down, you say, yeah, that's it. And then the machine comes in and takes care of it. So I have to say, I think the IRE needle placement is a little bit harder than you make it out to be.
No, I think
clearly better at it than me.
No, I think it takes time, and I think I wouldn't disagree with you. There's a learning curve to it. But I think what would be interesting as part of your IORT in that study that I showed for resectable cancer, I don't know whether that trial has started off or not, but if you are doing IORT after resecting the specimen, have you ever then considered taking that tissue and examining and seeing what happens to the cells there? Because it'd be interesting to just see, what is happening to the tumor bed.
Oh, so you're saying do IORT and then doing it. I think that the effects of radiation take longer than that hour that you need to get the specimen out.
Yeah.
So I'm not sure we would see much difference.
Yeah. But there is a learning curve to it, and I think we're getting better at it. And I think we're running workshops. It's a technology which is in its infancy, and I think it's doing well at the moment. But watch the space.
Excellent. If there's no more questions, I think we'll close this debate.
Thank you.
Thank you.
Thank you all for coming.
I was about to ask, because IoT has not the same flavor in Europe as in States.
The U.S. loves radiation a lot more than
Yeah,
Europe.
yeah.
Yeah, I mean,
Radiation
following
oncology is big in
Espan's